Good morning, dear international guests and our home network of university people, trainers and specializing physicians. We are about to start our second day and session number 3. I have the great honor to open this section number 3 dedicated to education and training in the field. My name is Leena Alamursula. I'm professor of occupational health in the University of Oulu. We'll be speaking a little bit later. But now, it is my great honor to introduce Professor Claudio Coloso from University of Milan, and I'm sure that you will tell us even more about yourself and guide us to ILO guidebooks.
Thank you very much and good morning. I want firstly to thank the organizers for inviting me here. It is an honor and a pleasure to be with you. And I want to say I'm happy to be again in Finland because I came here several times, and as I said yesterday in the dinner, I always feel myself at home with you. So I'm very happy to be here. Okay, sorry, I forgot this, because in Italy we keep, but any country different rules. So I will talk with you about the book we are preparing with a group of scientists coming from all the corners of the world. And by the way, yesterday I got the first proofs of the book, and then I can promise that the book will be ready by the end of the year, I'm sure. It is a big book. It is about 800 pages. And when you read it, don't forget that this is the product of the efforts of more than 40 scientists provided by a period of over 10 years. So, okay. I start the presentation with the definition of occupational disease provided by ILO. And you can see that both in 1964 and 1981, the definition covers both occupational and work-related diseases, because, say, exposure to risk factors arising from work activity, or in any case, arising from exposure to substances and dangerous conditions in process, trades, and occupations. So it is broader, the definition, than the one provided by several national legislation. I want to say that an occupational disease is similar to an infectious disease because it is linked with an external agent. Any disease linked with an external agent, of course, can be avoidable. So the ideal number of occupational diseases in the world should be 0. Unfortunately, this is not the case. This is a slide. I am a little bit jealous of Jukka because he showed yesterday a more adapted slide on the same topic, but the numbers are very close. We are talking about 400,000 cases of fatal accidents, 2.4 million of work-related disease fatality, and 100 millions of accidents with more of 4 days of absence from the work. Here you can see the burden of occupational diseases, global and European Union. I don't want to enter into details. I think that the numbers are self-explaining. You can understand. how big is the problem. And here you can see the distribution of risk factors in several areas of the world. And you can see that all the typical risk factors arising from work activities are present. And then East Asia is the leading area, followed by South Asia, etc. But the point is the most important risk factors causing occupational diseases are present in any corner of the world. Now I show you some data. That is the starting point of the third part of my presentation. They are data we collected during our work at Eurostat. That is all of you know what it is, so I don't add anything. And I was impressed by a data. I want to show you, to draw your attention to the fact that 3 countries with similar economical development and similar size show a very different trend of reporting. Please have a look at France. In 3 years, 50,000 reports per year for 3 years. Now you go to Italy, 21, 22, and now that is less than half. And now let's go to France. No, let's go to UK, 6,500. That is 1/4 of the Italian rate. So we have 2 hypotheses. The first is that France is very dangerous, Italy in the middle of the track, and the UK is very safe. But there is a second hypothesis, that is that the rate of reporting is different. So when I discussed with my colleagues this data, we decided to run some experiment, because I've shown you some data regarding the global incidence of occupational disease, but then I've shown you some data making a question mark, that is, how affordable are these data? How realistic they are? How they are collected? So this problem is linked with another problem, that is, which are the main, let's call, determinants of reporting of occupational diseases. In order to try to answer this question, we have run 2 sample exercises. So please forgive me, I'm not an epidemiologist. It is an exercise done among colleagues and among, let's say, my son, who is who got a PhD at the London School of Economics on developing countries and economics. So he helped me just to have the idea. So the first idea is, if we apply to the population of some countries, used as a proxy of the number of workers, of course, because we don't have the number of workers, and we assume that the reporting the same of France and Italy, which is the result, and which is a different with the official reporting. So we choose Benin, because the country of my friend Benjamin Fayumi recently passed away, and Benin reports about 4 or 5 occupational diseases in a triennium. But taking into account the population of Benin and the reporting of Italy and France, they should be 70,000 or 20,000, not 4. Then Burkina Faso, 16. And again, Italy and France 80,000, 107,000, not 16. So you can see that there is a big difference. And I don't think that in Burkina Faso, the fight against occupational risk has been successful, more successful than in Italy or Finland or France. Now, okay, for Africa it is obvious, you know very well. But what's happened with Europe? Slovakia, surprisingly, less than 1,000 reports, but if you apply the Italian rate, it should be 7,000, and France 9,000. And now Sweden, less than 500, and again these numbers. So, what's happened? Which are the reasons? Now we go on the second part of the exercise. We thought maybe it is economic question. But let's try. We considered units of 10,000 US dollars to identify similar country wealth, used a proxy for compensated disease, the reported cases, because the compensated is a number more difficult to get. And we use again the population as a proxy for the total workforce, and collected this data for a group of countries. Let's say well-known countries, and countries where my students of the 6th year of the International School of Medicine in Milan did an exercise. I asked them to collect data on the reports of occupational diseases. So simple, it is a starting point. I don't want to see that it is a complete, but this is what happens. If we consider these variables, we can see that African countries stay more or less together, and very likely the problem is economic. If you cannot afford a sound occupational system, and you cannot afford the compensation of diseases, of course, this is the situation. You create a list with a small number of occupational diseases, that's all. But if you go to the other country, let's say, for example, similar sites, Argentina looks very good in reporting. This is a logarithmic scale, because numbers were too spread to use natural number. It is logarithmic. So, why Argentina is so virtuous, let's say, whilst Public Republic of China has to do something more? And while Japan is here and France is here, similar economical development, similar income. So, economy is not the main determinant. Of course, wealthier countries can afford richer compensations, but other variables are in the game. For example, Slovakia has a list of 41 diseases, whilst France has a list of more than 90 groups of occupational diseases. This helps reporting, for example. And Sweden do not have any list of occupational diseases. So we have to consider this difference. A socio-political environment favorable to worker compensation, etc. Some ideas come from a study I did on the trend of reporting of occupational diseases in Italy in agriculture 2004-2017. Here you can see that something happened. The trend increases, and the main determinant of the increase are musculoskeletal disorders. So, what's happened? This is not a signal that in Italy we had a worsening situation in occupational health and safety. We are improving. So why this trend? Because here in 2008, we have the two new legislation news. One is a new list of occupational diseases with a more comprehensive and detailed list of musculoskeletal disorders. And the second is a law making mandatory occupational surveillance of worker in any workplace. So these two elements has been able to make visible what for several years was hidden, the not reported occupational diseases. And it is not by chance that here we see the decrease, because underreported has been reported. And now we slowly will go to the same situation or maybe even lower. So another determinant of reporting is legislation and the list of occupational disease. So a surveillance list, structure and characteristics of the list varying among countries. At the basis of the list, of course, there are criteria, because I remember a discussion with Jorma in 2005 when a failed an ILO meeting for the new list of occupational diseases. During our lunch, Jorma said, it is impossible. A list of occupational diseases is nothing without criteria. Criteria make realistic the list. You remember, Jorma, I think, our lunch. So, ILO appointed in 2011 a task force to prepare criteria for diagnosis and compensation of occupational diseases. I am very proud and happy to have been the chair of this group. We've been working 10 years. We've tried to consider the most important variables for the definition of occupational disease. And you can see that I watch, okay, timing. Clinical factors, which are not different between an occupation and non-occupational disease. Occupational exposures with measures, timing, natural history and progress of disease, and differential diagnosis. And then additional information such as minimum intensity of exposure, duration of exposure, latent period, induction period. That is more or less the well-known Bradford-Hill criteria, a little bit more detailed. This is the basis of our work. And now, this is the status of art. We have the list of occupational diseases, which has been revised in 2010, approved, after a 5-year process made of a failure in 2005, a new 5 years of work, and then the approval in 2010, after a very, very important negotiation with the tripartite components of ILO. It has been very challenging, but I'm happy and proud to have been a part of this. I think that when I will retire, I will say that this is the most important thing I've done in my life, so I'm happy for that. And this is diagnostic and exposure criteria for occupational disease. We call it guidance notes for diagnosis and prevention of the diseases of the ILO list of occupational diseases. Shengli, myself, Michele, that is a person of my team, and Adil, that is a person who worked very hard on that. Among the others, 40, 50 internationally recognized scientists, for sure Jorma was in the group. There was people from South Africa, from Colombia, from China, from India, just to give an international prospect of this work. And here, this I put tonight, because tonight I've received it. This is the cover sheet of the book. We have approved and it is ready. So you are the first in the world to see something that will be published in some months. So the book is made of about 100 mini monographs. We have prepared a mini monograph for each of the items of the ILO list. The monograph was drafted by an expert, then was revised by the whole group, then was changed, and then again revised. And I want to tell you that some monographs did this track several times, even 6 or 7 times, because the opinions of experts are different, but the decision was only on consensus we will publish, because it is too important, this document. So only consensus, and I want to tell you only grounded information. We decided not to consider the new paper on the new disease. This is matter of something else that is modern at our research activity. Here we want to put the level of knowledge. This has been our effort. So we have a chapter on general characteristic of the causal agent, description, or of the disease, occupational exposure, then toxicological profile for chemical agents or biological mechanism for physical and biological agents, my main health effects and diagnostic criteria, and here key action for prevention. I want to tell you that we added this starting from 2008, when the representatives of the workers asked us to add this chapter. We are thinking, it is done. No, they asked us to do also this, and I think they are right, because this is a very important chapter, how to manage prevention. And then further reading, that is a collection of reference to be read to collect further information. Then we prepared also for the occupational diseases and other diseases, and here again the structure is similar, short profile and of the etiopathogenesis, occupational exposure, etc., etc. Because as any other list in the world, or more or less any other list, because some are different, the ILO list is an hybrid list. Some parts are for agent and some parts are for diseases. But I'm convinced that this is the best way to manage a list. Also, the Italian list is in this way. We discussed it a lot just a few months ago about how to produce the new list. We decided to maintain this hybrid list. Okay, and then a specific chapter on occupational cancer, not considered among agents or among diseases, but to highlight the particular relevance of the topic, occupational cancer, to draw the attention on a very important aspect for prevention. So this product is a effort of voluntary scientists. All the main geographical areas of the world are represented, will be printed and digital to allow everybody to download 800 pages. It takes a while, but it is good. And printed form for those who cannot manage internet day by day. And really, I think that if this will be used, it is a unique tool to promote harmonization, to the approach to recognition, diagnosis, prevention, and compensation of occupational disease. I want to tell you a last point because I want to remain within the limits, time limits. I want to tell you that we discussed a lot about the problem of having in the same list compensation, diagnosis, and prevention, because prevention is based on the precautionary principle, but of course diagnosis cannot be done on the same principle. But this is something we have explained, because precautionary principle goes for definition further than the knowledge. If you think that some agent might do something, then you must protect worker, but you cannot do a diagnosis at this level. So that's all. I hope you will appreciate the work, and I'm really proud to show you this result. I'm very grateful to the Finnish friend for inviting me to do this presentation. Thank you very much. I'm ready for any question. Thank you.
Thank you so much, Professor Koulose. We are at the basics now. I wonder if there are any questions in the Presemo. And I forgot to tell to people here that if, in case you were here, not here yesterday, in the Virtual University of Occupational Health, you will find the address to Presemo, which is the communication platform. There is a question coming from Heidi Furu, please.
Grazie mille, signore. You're doing extremely important work, and I would like to use this opportunity to remind all of us here that this under-detection of occupational diseases is something that concerns also Finland. We cannot afford to be proud or arrogant here that in developing countries they are not doing this job. We always are proud of our system when we have these obligatory health checks and health surveillance for exposed workers, but still we have underdiagnosing. It concerns at least occupational asthma, hand-arm vibration syndrome, chronic solvent encephalopathy, and probably others too. And one of the reasons we found in our research is that common health concerns and lifestyle issues, they overrule the work-related things in the health checks. And that is something that comes to our everyday life when we are working as occupational health physicians, because it does matter what we do there in health checks. And it's our duty to take care of that we do what we are supposed to do there. And I assume the same kind of things concerns other countries too. That wasn't a question, more like a comment, but thank you.
Yes, I can only say thank you because it is a comment, so I do not answer anything. Thank you.
Thank you so much, Heidi, for this important remark and for the work you have done for this. Next, Jukka Takala, please.
Thank you. Excellent presentation. I really appreciate your long-term work for this particular item, and I think you had very good and nice conclusions. One comment is that we could also consider one aspect which is behind many of those decisions what to include in the list of occupational diseases, and I would call it something like what is the society or country's ethical attitude towards occupational diseases. So the higher is the ethical consciousness, the higher is the list the bigger is the list of occupational diseases. That's an important thing. Second thing what I wanted to comment is to say that perhaps we could easily look more rather than the GDP per capita, we could simply look at per number of workers in a country. So then suddenly we get the worst country in the world is Denmark, per 1,000 or 100,000 working population. And that depends that many of those what are not compensated in some other countries are musculoskeletal disorders, some psychosocial factors. They might never kill people, but they lead to long time of sickness as well. So this comes also from the ethical point of view that employers don't want to include those in the list because it will be financially big burden to pay more. So this important thing that what is health more important than the economy again? But one question particularly to you is to look at, did you identify something or some guidance or some possible criteria for those ILO list items that are called open items? The list what can be, the list is not closed, but you can add other items on the list what when scientific information is good enough to include them. So did you consider that what are the possible criteria? For example, we discussed in the meetings in the past of the ILO meetings that IARC list for cancers are coming gradually higher and higher. It takes sometimes years and years because they are finally agreed by IARC. But once they come, then one could add those. So did you look into that particular item?
Sorry, is my timer say that my half an hour is expired. I use thank you very much, Yuka. Very important comment and question. So I start from the question regarding open items, and I want to tell all you that open items is very important from a strategic point of view because a list can age over time. And then some new item should be included, but the time to prepare the new list is long. So if there is not the possibility of compensated also further than the single item in the list, maybe some diseases are not covered. So the idea of adding the so-called open item, that is any other disease whose association with exposure can be demonstrated is very important. I want to confess you that we tried to prepare a list of possible open items. We also prepared something like 25 examples of open items, but then we decided not to put in this version because we decided that they were too few. So we will work in the future to prepare the open items. As for ethics, I think we must be able to disseminate ethics. There is the ICO code that is a very good starting point, but I share the opinion that this topic can be addressed only based on very strong ethical principles. Okay, thank you.
Thank you so much. And then whether there will be questions from the Presemo and then one for Rita, then we continue. Okay. Okay. Heidi, choose maybe two most important there, and then Rita, and then we'll continue, and I will cut minutes from my presentation. So Rita, please. Rita, please.
Okay, thank you, and thank you for the very interesting and informative presentation. We know that the EU has been working on a kind of similar list and criteria, and you have been also involved in that process, I think. Could you kind of compare these two lists of occupational diseases, the list of ILO and the list of EU? How do they differ, and what is the current situation of the EU list? Thank you.
Yeah, let's say the main difference, thank you very much for your question first. The main difference is that the European Union list has also a list number 2 of possible occupational diseases, and this is in line with, for example, Italy and other countries. I think that having a sub-list of possibly and or probably related to job is very good, but not for compensation, but also only for reporting. Because, for example, in Italy, we decided to add or to withdraw some item from the official list for compensation based on the result of reporting. Example, celiac and autoimmunity is possibly, but if you don't have in 10 years any report regarding autoimmunity in celiac exposed workers, then you can conclude that at least in the country does not exist. So this is the main difference. Then there are other differences. For example, minor nystagmus is not present in the European Union list, but this may be because the working conditions in Europe now are such that minor nystagmus is not observed anymore, but may be observed in Colombia, for example, or in Ethiopia. And finally, musculoskeletal disorders in the European Union list are part of the physical risk factor, biomechanical risk. But let's say there are small differences, more or less the diseases are present. And also European Union did a book of criteria, was published in 1997, and then the new version 2008 is a little bit smaller than this is one, is 200 pages, and I was in the group for both these books, so I did some small work on that also. Thank you, Rita.
Okay, thank you. Then Heidi, something important there.
Yeah, I combined two questions. First one is, what are the most common occupational diseases in Italy? And also, do you what is your opinion of including burnout to the list of occupational diseases?
Okay, thank you very much. The first is very easy. Musculoskeletal disorders, as in any other country of European Union. In Italy, the weight of musculoskeletal disorder is about W of all the other diseases together. So it is really a trend in the whole European Union. As for burnout, I want to tell you that this is a very critical problem. I want to tell you that in the list of ILO, there is an item that is post-traumatic stress disorder that is not considered in several national lists. So a little step to consider psychosocial risk factor has been done by ILO. In my opinion, it is still a little bit difficult to get consensus, because I remember in 2005 we discussed about burnout, we discussed also about malaria as an occupational disease. But in the tripartite discussion, the employers said niet, no, nine, very strongly, because if you have not robust criteria and possibility of identifying occupational versus non-occupational cases, the list will create a burden of compensations that for the employers is too much. So I think that it is a pity not having, but I want to say that something is better than nothing, and therefore we must consider for some specific risk factor the problem of having criteria robust enough to be sure that we will not compensate any case of malaria or any case of depression in workers. I hope I have answered. This is my opinion.
Thank you so much. So I will switch now to a presenter and cut my minutes from this very important conversation. Thank you. Thank you for this ground-lagging work you have been doing with creating these criteria, creating this thinking, creating these lists, making these issues visible to the totality of healthcare. Thank you. Originally, Kari Reula was supposed to talk about curricula for Europe, but circumstances being as they are, I try to cover him by presenting the strategic choices for occupational health curricula here in Finland. And there we go. Asking some questions: why, what, where, who, like a 5-year-old would ask, but to make some points of view. I'm cutting from here. What are the issues? What are the exposures? What are the strains? What are the good points in work? What all can affect your health? What all can affect your state of functioning and workability, changing all the time? And that's why not only the lists, but also the ways of thinking, the criteria, the way the occupational health physicians should think, they are so important, and that there are things that we need to educate. The society is more and more there in our discipline. Because of aging societies and the global economies affecting all working life, all the basic elements and circumstances there, which we need to kind of master in order to do the good things, to prevent work-related diseases and to help people cope with their diseases at work. Kristiina Mukala already yesterday stated why. Why do we need occupational health care medical specialist education in this country? Because we're good people and the law says so. And we have a wonderful law. Law protects the weak ones. This is really a consensus society in terms of the good aims of this act. Our government also urges us to develop occupational health services, which means that we need to develop the knowledge and the know-how behind the services. And there's a good task list of what to do and develop in the coming years. Kristiina Mukala is also the mother of this picture. She showed the version with the triangles. Her beautiful picture has been modified in some of very important national projects, and this was Työke project, national one, that developed and put the same thing in balloons. Whether occupational health care system works at the boundaries of the different parts of healthcare or in the connecting channels between these with these portions of healthcare system is a good question. But the important thing is that all these different sectors have different missions. They have different aims, different focuses, even different ethics. Like in the previous presentation, the ethical aspect is more important than we might think at face value. There are several areas of healthcare sector that think that it's unethical to ask the profession of the patient in order to be able to provide equal care. And it breaks the heart of an occupational physician because in that line of thinking, which somehow makes sense, if you think that the same for everybody is the highest value. But it really breaks the heart of an occupational physician, because then you forgot all about the basic exposures that might make you ill, and the basic elements, where do you use your health, and not having a balanced view of this occupation affecting your health and ability is an issue, and in a way the government sees that we have something to give in this cooperation. It's our task and our duty to take care of where do those people come to health care encounters, and where they go from after we have treated them, because it is a key issue in terms of health, providing important ground for the functioning of the whole society. And we are the one part of this healthcare system that has natural and hopefully living connection with the working life, and we breathe the same air and people in the working life and follow those things. Then there are these legislative issues and the society issues, but society and working life, they are very much intertwined. So it's only natural that we work in the connecting channels and boundaries, and we as educators here in universities, we need to think what kind of knowledge, what kind of know-how, what kind of cooperation practices, processes are needed, and of course an important issue is also what kind of management, what kind of leadership, but then that's beyond our tasks. But our responsibility to speak out clearly what is the knowledge needed in these cooperations, and what we can give for wise division of work for common good. Healthier workplaces, healthier employees, more better work ability for the employees, productivity, innovativeness, whatever. A functioning society, sustainable society. Then another why. There's work to do. Again, in the legislation, there are occupational health services to be provided, and this country has legislation that if you are an occupational health physician full-time, you need to be a specialist, at least a specializing one. So and the volumes are huge. They are not easily wiped out in any healthcare reform, which will which raises concerns at the moment, because the local solutions are going to be very different, and we really need to speak out loud how we can help the totality. Our choices. Who are we? The national network representatives here today with us. It's a large number of specializing physicians in this country, and we are happy to have 300 university-approved trainer doctors. The ones with the light in their head are with us, providing this specialist education. And we have university-approved training centers that actually develop the whole field in this sense. But without special arrangements, it would only be 5 professors taking care of all this. Everybody sees it's impossible. Luckily, we have funding, a special act for this, and by this means we have a clinical lecturer in each university, and with part-time arrangements, we have a nice network of 30 people with 13 person years. We are so privileged to have pedagogues with us, and the virtual university, and we share the work. There are courses that Tampere arranges, something that Helsinki does, something we in Oulu do, and everything is available for the whole national community. And with this shared action plan, we also can guide what is important, what next, and make our choices visible. and we take care of the network in the field. We try to be as working life oriented as possible. The whole medical specialist training in Finland is under reform. It's regulated by the Ministry of Social Affairs and Health, not the Ministry of Education and Culture, which otherwise regulates universities. So there's a nice little tension there. And there are some regulating elements being created the last years, regulation by numbers, and then new decree for the thing. But importantly, the government wants us to be more and more competency-based instead of time-based. So more and more conscious of what is going to be learned and how. And these days, when somebody starts with the new rules, he or she needs to prove that, no, I'm ready, now I'm qualified, and we need to set the criteria. How do we detect one who is now qualified? Why is he or she qualified today, not yesterday? And that's why we were urged in all 50 specialties and of medical specialties and 5 dental specialties, we were urged to define our learning goals. And we were given 2 options. Please state the competencies or the entrustable professional activities in your specialty. I'm not going to details, but these lead to a bit different wordings on what you're going to learn. Because the competencies are personal. When I have the competency and I walk out of the door, the competency walks out of the door. But if the goal is set like the professional activity, if the thing you need to learn is written as activities, the activity stays here even if I walk out of the door. But of course, still you need both. And skipping the details, we defined our learning goals. It was an evolution, not a revolution, because essentially the goals have been the same since 2015. We have written our learning goals as in the words of the tasks of the whole discipline. In the division of healthcare work, these people are those who know the relationship between work and health. These are the people who know how to evaluate workability and also how to support it. 2 different logics that you need to intertwine with. And these are the people who know how to work with the workplaces, which have a totally different ways of working than compared to the healthcare sector, private organizations or even public organizations. They are not there for promoting health. They are there for other purposes. So how to make good things happen in this field? So these are the 3 main elements that differentiate us from any other specialty. And then we have kind of packed the central professional activities that our people do in the everyday work. So it's also fair for the learners. Those are the activities I need to learn. And of course the competencies are there. We need to understand medical science, ethics, legislation, whatever, and develop ourselves as specialists, experts. And then we need to try to foster the internal will of understanding work and health. We have theoretical contents. We put learners reading books, following journals, and then we have this virtual university where we can showcase the important topics. And of course there are the old topics, but now talking about these lengthening careers, we need to expand our view from specific workplaces to employability for changing work in at times. And that is a different logic again. And And where do we do this? Where does this learning because essentially this is learning at work. It is for work as universities goals set goals need to be fulfilled, but also essentially it's learning from work, consciously, but also accidentally, and guided, and making plans. Okay, the plans are there. What do I not know yet? What to do next? And make it somehow consciously and well planned. We are so happy that we have this trainer network, and they are pedagogically trained to make most of our common time. We have already several ways of assessing learning. We have good routines for periodical checkpoints where we can sit down and think of what have you done during the last months, where do you think you are, what are the goals, and making plans. But now the new reform urges us to also use direct observations of performance, and that is new to us. How can we adapt these ideas in our network where we work all over the country, and the supervisor and the trainee are not necessarily in the same room? How to observe in such situations? We don't know. So next we are going to develop the assessments, and of these first 3 goals we have chosen to emphasize the importance of assessing performance in these professional activities. We need to prepare processes and practical tools of grading the phase of learning, and we have done that this autumn with our beautiful trainer network. And we will start with 6 essential professional activities, large entities that you cannot learn in a few months. So larger entities where we can monitor progress towards the goals, and that's what we are going to do. We have defined the milestones, the scale of evaluation. We don't know how it works. We will start. We are actively working with the national network to understand, not only understand, but to actively influence the way our national electronic logbook for all specialties is going to be prepared. And we have been able to include our central elements in this development. And we are creating a mobile logbook to help understand the level of progress, and this is going to be a platform enabling a larger view. There will be parts that the specializing physician runs privately, and there will be parts where a university professor can see the big picture, where what's happening, where are those people, but how does this work? We are so happy to there are people going there. Raise hands, Tommy, Johanna, Katja, we have people here who are going to be part of this pilot, and the idea is that it will be ready for all specialties next autumn. To conclude, we are so proud and happy, humbly happy of this beautiful national network, which enables us with these figures. We have clarified our learning goals. We hope that they help to place occupational healthcare as a partner between all other sectors of healthcare, and we expect to be able to work for better society, sustainable working life, and many common good things. Thank you so much. And I don't accept any questions now. Instead, I am going now to welcome here on the stage Professor Alenka Skerjanch. Was it well? Who will come to lead us to European spheres now. Please.
Dear colleagues, dear young colleagues, thank you very much for the invitation to be present at this very important meeting, to the organizers, especially Professor Kari Reijula, who is unfortunately not staying with us, to Professor Rantanen, and also to Professor Takala, who supported us in having a special session at the next ICO meeting in spring 2022, when the European exam in occupational medicine will be introduced more in details, and also from the perspective of participants, trainees who participated in first European exam, their experiences and their expectations. So, after thanking to the organizers, I mentioned yesterday, it is a special privilege that we from Italy and me from Slovenia were able to come from Mediterranean, from the southern side of the Alps to the shores of Baltic Sea. It is really a nice and very optimistic experience for our future collaborations as well. Yesterday, I also mentioned by dinner that we are strongly connected in our daily work, experiences, expertises, and science. But with this presentation, you are also going to see that we are connected very strongly in administrative way in Europe. Why? Sorry, I will go back to start. I represent here Union of European Medical Specialists. It is very old organization, rather old, and all the medical associations in Europe that give licenses, the doctors of any specialization to practice, are the members of UEMS. So all of us who have license to work in occupational medicine, we are, whether we are aware or not, members of this, the biggest European doctors' organization. And every country has got 2 representatives in the Council of European Union of Medical Specialists. And it was, I think, 3 mandates ago where Finland had the president of this huge organization. He is a gynecologist. Just a moment to remember his name. I will tell you later when my memory gets better. Yes, it was Professor Dr. Hannu Halila, yeah. And also the Finnish representatives are very active in our section in occupational medicine. The current representatives are Professor Reijula and Satu Ranistu. Unfortunately, she is not staying here, but one of the most active representatives from Finland. She was Ritva Aro-Helimäki, whom we are very sorry to pass already. And also, it was the man who has been retired already, also very active. I'm also getting, I'm going to remember, and I will tell you later. So now let's move to occupational medicine. Lena mentioned in her lecture that for occupational medicine, it is very important or the most important, and what makes us different from any other medical specialty, is to find connection between work and health, and especially being every time ready to prevent the diseases, not only to detect them. So Ramazzini started with this book, printed in Modena. You see how many years ago, but the basic principles in occupational medicine have not luckily been changed in basic principles. Because of our preventive activities, we are not allowed, and I think we also do not wish to stay and wait what's going to happen. We wish to be active, and we saw by presentations yesterday how occupational medicine is alive and very important and visible all over the world in anti-COVID activities, in preventing COVID, and also in trying to give the answers for after COVID times, which is also very important. UMS as organization, I'm going to present you a little bit. Our organization is not so old comparing to the history. We are very young. And following these slides, you are going to see that in fact UMS is basically a politically based organization. It started because the founders of European community wished to enable movement of doctors inside European Union. But if you want to enable free movement, you have to achieve certain quality. In our case, certain quality of medical doctors. So they wished to define the basic principle in the field of medical specialist training in Europe. Going further on, to enable the medical training in Europe, they decided to base sections of medical specialists, and also occupational medicine is one of the sections. And they wish to achieve, as I said before, a high level of training for the future European medical specialists. And they wish to elaborate the common general criteria applicable from the standpoint as from UMS organization to all specialists, not only to surgeons or internal medicine or pediatricians or whoever, but for any medical specialty. On the basis of this European opinion, also the Directive 2005 306 European Communities was written to enable the free movements of medical doctors and architects within European member countries. In that time, European community was not as big as it is nowadays, almost 30 member states. And it was, I think, a little bit easier to combine and organize everything. But however, as European Union was growing, also the strength of UMS and medical specialties was growing up. When I mentioned the medical specialties, it is not only the knowledge and the expertise, it is also to create the personality of the doctors. You know very well that in old times, the language of the doctors was Latin language. And even when I was a medical student and when I trained occupational medicine, we set diagnosis in Latin language. Nowadays, the basic language of medicine is English language, and we are setting, in most of the countries, the diagnosis of the diseases in our national languages. Is it the same in Finland? No more in Latin language. But there was a question in this article, who is the good doctor? Whether it is that one who is speaking Latin, whether it is that one who is speaking and learning and presenting the topics in English language. But it was concluded that the good doctor is that one that can and wish listen to the patients, in our case to the clients, because basically we don't have patients as ill persons, but we have employees and workers whom we wish to prevent diseases. We have to communicate with the employers. We have to communicate with trade unions. Our clients are also governmental offices. So we are not limited basically to the sick people, but our field of work is much broader, and we have to learn to have these competencies to be able to persuade all the partners what we are thinking to be the best for the working force. Now I said that there was specialist training, the highest aim in European Union of medical specialists. And our section in specialists in occupational medicine is rather young. We were born in 1997. But nevertheless, what we achieved as a section is very strong. I'm going to explain you later. I have to go back. Every specialty was urged to prepare the basic training program. This is the European training requirements for any of medical specialties. And it is quite a complicated process because it has to be achieved by the prepared and also approved by every member state who is active in medical section. So when we were preparing European training requirements for occupational medicine in 2010, all the national representatives were active in that work. And it was the consensus of all the countries who are active in this group that this is the final point. We are never ideal. And if we are going to wait until we are the best, we are never going to achieve this goal. But it is our task to change and improve the requirements as there are the times coming on and the times bring the changes we have to follow. But if we are going to wait, it is just losing time to be active. However, when these European training requirements in any specialty are adopted by the national representatives, then this proposal goes to the Council of European Medical Specialists. In the Council, there are 2 national representatives of all European member countries. But to be true, there is any European country to have a national representative being specialist in occupational diseases. Most of them, there are surgeons or specialists in internal medicine sciences or pediatrics or neurologists, but not the representatives of preventive medical specialties. So the one who is representing the European training requirements for any specialty has to be very good in explaining to the council, and then they agree or disagree with the proposal. So at that time, when I was presenting European training requirements in occupational medicine in 2013, there was only one voice against our requirements. So we were very successful, and there were 6 medical specialties proposals, and also 3 medical specialties passed these requirements or voting or whatever to say. So it means that we were able to persuade other national representative and medical specialties that our requirements are done and prepared very well. Then when you start to prepare, you know, every medical studies finish with a kind of exam. And also when we were preparing for final European exam in occupational medicine, we also had to pass the requirements of CESMA. This is the Council of European Specialists Medical Assessment, and you have to provide and explain them how your exam is or was prepared, and how it looks like, and what are the demands, and what is the threshold, and how are the questions done, and so on and so far. And when you start with the exam, you have to invite the observers from this sub-organization of UEMS to check in line and on site how the exam is going on. Just to remind you, the European training requirements, it is too long to write them down. You can make a photo, or you just can take a look at UEMS Occupational Medicine section, and there you will find all the data on the requirements, the curriculum, on the exam, on how to apply for the exam, on the basic literature, and so on. Just to let you know, all European countries are now changing the curricula, and the aim of the UEMS is to adapt our national curricula in any medical specialty to European training requirements in surgery, in pediatrics, in neurology, also in occupational medicine. And there are many countries which I discuss with the colleagues to take these 10 topics as the basic of our training. But the countries differ to each other, not only on legislation, also on tradition, on culture, on different perspectives. So we are all free to obtain our national specialties or specific matters. But anyway, the basic frame should be the European one. And there are framework for practice, as I mentioned. Why is occupational medicine, or what are the most important points that gives us importance comparing to other medical specialties? Why we are so special and why we are so important? So to raise the awareness of the occupational medicine, not only because of COVID, but in general. Then there is clinical practice, fitness for work, rehabilitation, disability assessment, and the hazard recognition, evaluation, and risk control is the most important, the hugest part. And also, if you decide to take the exam, there is the majority of the question falls into this topic. Then there is business continuity, disaster preparedness, emergency management, service delivery and quality improvement, which is also very important, leadership, policy development, professionalism. And as I said, we don't have the same labor legislation. We are different. So the national legislation doesn't fit to any of this topic, but what it is necessary to learn and know about is the ILO Code of Ethics. This is the basis also for occupational medicine exam. Because occupational medicine is not only practice and activity, epidemiology is very important, preventive health is very important, and research methods are very important, so that we are included in the same quality of work as other medical specialties. We are also researchers, as Professor Colosio told us, and there are many researchers in occupational medicine, and also effective teaching and educational supervision. This is what I was heard just with these lectures, how strong you are in Finland, and also teaching. It doesn't mean also to teach students and trainees, to teach employers, to teach employees, to teach trade unions, and to teach politicians. So we have to be very strong and skilled in communication as well, not only in basic medicine or occupational medicine. So there was our colleague from the pediatric sections, and he compared to prepare a good doctor is like preparing a cake. There is not only a recipe written, because if there is only online training or only books, we cannot educate a good doctor, as we mentioned before. The doctor that can listen and understands all his or her clients. There is a long process, and that's why you have trainers. You are very rich in trainers to give a human note, to give a communication skills, to give many things which doctor needs to be, excellent in preparing his clients, in understanding the combination between work and between health and their influences. But at the end, there is certifying exam, of course. We cannot get a mark of being a specialist without passing the exam. The first exam in occupational medicine was provided in 2021 in Brussels, and we were checked and controlled, as I said, by SESMA. And we were very happy because we passed SESMA accreditation process in the first run. And we were the first specialty who succeeded that in first run. So it means that our national representatives and the colleagues who were preparing the exam, Kari Reijula was also within the group that was preparing the first exam, were really good to pass all these checkups and controls. The second exam was, although there was COVID, we decided to have it, because if we stop after the first run, we wouldn't give a mark to be well prepared and strong. So we were just deciding the right time, and we supposed it would be August, because it's not a good time for virus to spread. All the people, all the Europe, the flights are open, so we decided to have it in August, and we succeeded the second run, and the third run is going to be probably at the end of August 2022. It depends on COVID or pandemic situation, but nevertheless, there is going to be the third run in 2022. So also the Finnish colleagues are invited to apply for the exam. The participation fee is rather low comparing to other medical specialties. It is 700 euros. It is paid by person, but to say from the countries that their participants apply to the exam, their employers or payers reimbursed them the costs, because having European exam was very important from the provider of occupational medicine services, because it means the trainees who passed European exam, they are skilled in English. So they are very, let's say, well done for the employers, for the contractors, even from any other country. And it is also a very important benchmark for the trainees themselves. So it means that they are good and comparable to other colleagues from any other European colleagues. And that young colleagues that passed the exams started with a network, because they got known each other in Brussels, and they are still connected with each other on many fields, not only on scientific or work activities, but also personally, what is also very important. You can contact the person you personally know. It's very difficult to make contacts anew by mail only. And there is also very interesting that the exam is open to the whole world. The only demand is to be at least in the last year of training in occupational medicine. So in the first run, there were colleagues from Belgium who already are specialists in occupational medicine, and they wanted to test their knowledge, whether they still fit the current European requirements in occupational medicine. And they passed, and they were very proud and very happy for that. European exam is not an obligation, and at the moment UEMS and European politics do not demand to be obligation, but as I told before, it is the proof of excellence, and it is opening the door to the knowledge and to collaboration and to cooperate with other trainees. Mostly you are young and you are the future of occupational medicine, and it is very nice to be in contact. Well, about digital transformation in COVID times, I mentioned before the exam tests only knowledge. It cannot provide any other skill. Where are there the experience, empathy, ethics, and this long-distance work, long-distance training? I was a bit sorry or afraid for my trainees in occupational medicine, how they are going to behave if they are sitting on the computers all the time. But time always brings answers, one way or another, usually in not expected way. So in the first wave of COVID, Slovenian trainees in occupational medicine, they had to pass the course in intensive care and also the course in ventilation. And yesterday, all the trainees were called on site because the situation is very difficult in my country at the moment. So experience, empathy, and ethics is going to come to the first run. Thank you very much for your attention. My time ran off, so for the discussion, I am inviting you maybe in break time. If you have any question, I am ready to explain and say thank you very much for listening me for a bit longer time.
Thank you, Alenka, so much. How many Finnish students have passed this so far?
Anyone was applied for the exam so far.
Okay.
So I am inviting.
Okay, good. Thank you. Okay, who will be the first one? Yeah, that's a good question. Will be rewarded in this seminar, I promise. We move forward, and now we are going to have a virtual presentation from Professor Begoña Martínez Jareta, if I pronounce it right, from Zaragoza, Spain.
Good morning. It is my pleasure to participate today in this Congress, and I want to thank to the University of Helsinki and the organizers, particularly to Professor Jorma Rantanen and Professor Kari Rijula. Also for their support, I want to thank Marit and Asta, and I want to give thanks in the name of EASON for having invited us to talk about the EASON mission and OM, occupational medicine, education and training before and after COVID-19 pandemic. EASON was founded in 1993. Its mission was to promote cooperation between institutions involved in the training of medical doctors in general and specialists in occupational medicine in particular, as well as other occupational health professionals. Furthermore, to develop the exchange of knowledge, skills, and experiences in teaching and training between EASON members institutions. The vision added value to member schools via access to European academic networks, improvement of European teaching for students' curricula, specialist training and continual professional development, exchange of students between EU countries, and development of a quality assurance system for education and training that could be endorsed and adopted by member schools. To put all this into perspective, we can say that EASON mission and vision made enormous sense at the time our association was founded and still does. At that time in Europe, the so-called Framework Directive on occupational health and safety had recently come into force. The Erasmus program has been also launched and various directives are being issued to facilitate the mutual recognition of professional qualification and diplomas, all that to ensure the free movement of professionals among member countries. At that moment, and still it was clear that effort must be made to define common competencies and harmonize the minimum training requirements for each profession. And I have to mention also the Bologna Declaration in 1999 with the idea of creation of European higher education space and area. The challenges faced by EASON have evolved over the years. In order to respond to these demands associated to each moment, EASON has launched different initiatives and developed a variety of activities. Finally, he has also contributed to the achievement of important objectives in the field of occupational medicine training. The activities offered by EASON are a number of them. I'm not going to get into detail of all. They are here in this slide contained, and always and only I will go in detail in some of them, especially to summer school. EASON Summer School has been, over the year, a constant source of exchange of experiences, ideas, and other things among EASON members, and a space for meeting, for fostering partnership and cooperation, as well as unique occasion for enjoyment in beautiful places all around Europe. From north to south, from east to west, have been taking place EASON Summer School for the last 20 years. Also, EASON carry out projects and has participated in the development of a number of European projects and Erasmus projects and occupational medicine teaching modules. We started with a learner project on risk communication for workers about health and safety issues, and we follow with other important projects as EMUTON, led by Professor Ludwig Bregman from the University of Ghent, and Virtual Patient Project led by Professor Katja Radon from Munich. Both of them has been awarded and both of them must be highlighted. And at present, EASON is supporting a new EU project, which is on digitalized education in Europe beyond the pandemic. Again, virtual patients and problem-based learning that has been launched and supported, as I said, by EASON. This is only a very short summary of this project. I want to highlight Emuton, a free learning module. You see there the website, the link, with the minimum training contains in OM for undergraduate medical students in the European community. It was considered a successful hit by the European Union Directorate General for Education, and it's been in use in many universities of Europe and outside Europe also, in Turkey, in Egypt, and other countries, as I said, outside our continent. And finally, it has been created a comprehensive virtual patients database, which has been translated and now is available in several languages. As I said, this project has been also awarded and is very prestigious and well recognized. And here we got the link for those that are interested in the project we are working and supporting now from EASON, and that is open to collaboration with other partners in certain tasks we have to carry out in the next future. Interesting for all. We offer also the bulletin with the news and summaries of our activities and some statement and position papers. I want to highlight the last one that was after the Riga Summer School in 2019 that was published in the International, Journal of Environmental Research and Public Health, and put on the table the importance of training at different levels, training doctors, training nurses on occupational medicine, also to aware on the importance of occupational cancer. Undergraduate training of occupational medicine has been a question and a concern for EASON members. And this is because we realized with this survey that a number of European medical schools do not include occupational medicine or occupational health at all, or if they do, only few hours are devoted to this subject. This is not good, it is clear, but it is worse if we consider that has been described that poor training, it is accompanied normally of a negative attitude of occupational medicine, of occupational or towards occupational health. However, or on the contrary, training undergraduates at the medical schools in occupational medicine has shown to raise awareness and bring about a positive and significant change of attitude toward occupational etiology and war-related diseases. We can understand how important it is the achievement of this goal of have a good training of medical doctors and the medical school when they are undergraduate from the very beginning and before to the specialization also. EASON, it is now having room for members from 19 countries in Europe. This here, you can see here the list of the countries that are represented in EASON. In our last presential summer school and in our Riga statement that was published in 2020, it was said and conclude that medical school, universities, and international scientific associations have a crucial role to get this recognition and adequate training in occupational health and at this undergraduate level. University centers are connected internationally and can cooperate in achieving essential goals, such as developing a standard basic curriculum in EU countries or establishing minimum training requirements in occupational health for health professionals and others involved in occupational health. IASON has been also involved in other levels in postgraduate training, and particularly in the training of specialists in occupational medicine. Considerable effort has been made to have a basic common curriculum in Europe, to establish training standards and promote standardization in occupational medicine specialist training within the European Union. From defining the competencies to evaluation, IASON has participated and support all the tasks that has been done to develop this training and this common curriculum for specialist training in occupational medicine. In this slide, you can see that IASON was participating from the very beginning in the development of the agreed European competencies of occupational physicians. I'm not going to detail that. This is only to show you how involved has been from the very beginning. Recently, an European exam in occupational medicine has been launched by UMS OM section and has been in collaboration with IASON that has given full support to this initiative. In fact, the seed of this IASON, European exam started nearly in 2014 on the occasion of the summer school, IASON summer school at the University of Glasgow. And in that moment, it was starting the process to establish MCQ, multiple choice questions, after approval of the ETRS, and 10 small working groups on the ETRS topic were created. And they have been working on creating a database along the year with collaboration of IASON. Some IASON members have been very involved also in the proposal of MCQ question and in this data bank. I'm not going to be very deep in the topic. I think Professor Alenka Senhart will comment on this, but I must highlight the importance of this first European assessment in occupational medicine that likely took hold before the outbreak of the pandemic. It took hold the 23rd of January of 2020. It was really a moment very special for us, and it was the result of deep collaboration between different societies that there were not so in deep collaboration until that moment, but even they were before. And the exam was approved by SESMA, and when we were there, observers of the official observers told about this or comment about this exam like a real milestone in the history of occupational medicine. From my point of view, it is really a very important step forward, and it has been very good that even in the pandemic time and even the worst situation we have to face, we were able to celebrate the second European appraisal this at the end of this last August in 2021, to keep working, to keep going this examination, that it is important for our specialty, and it is important for harmonization also in assessment. So we are very happy with this result of good collaboration, which is always very, very critical in and much more for our society, which is not a powerful society and needs to be visualized still. So we were really happy. And I must say that we put quite a lot of effort on this. Of course, members of UMS, and particularly the president of UMS until this year, Professor Alenka Senhar, and of course, Kari Regula, Francesco Cova, Simon Balteris, that has participated also as examiner in the second appraisal. And we could celebrate because behind the scenes, there is a good understanding among persons, a good understanding about good colleagues, sorry. So this is why these things work and why we succeed at the end of the day. We were talking about the pandemic, and we were on the pandemic, and we have to reinvent it ourselves. So we decided to create, to use another sources, and we started to produce and offer a webinar that could be interesting because the topic, and very interesting also because the speakers. And so we had again very good colleague, this time from Modernnet group, to which some of us belong, and we are very happy to belong. So we got also Professor Claudio Colosso, Professor Lode Goderis, and Raymond Agius that fortunately are also in this Congress, and unfortunately for me, I'm not going to meet like my other good colleague I mentioned before. Well, in time of crisis, there are some opportunities. SARS-CoV-2 pandemic has been terrible, has been very tough for medical doctors, very demanding, and has created a lot of struggle for occupational physicians. But COVID-19 pandemic brought something good, which is the essential role of the occupational physicians has become visible. And this is not very common. We need visibility. So we think from EASON that this is a good opportunity because we have quite a lot of challenges, much more now because we are still in pandemic crisis. But there are a list of unresolved issues that go back years and need an adequate response. For example, no proper appreciation of the key role of our specialty, misconception that persists that occupational medicine represents the employer interest. This is a misconception that is still is there in our workers, that they prefer to go to the medical doctor at the National Health Service before to go for counseling, even to the occupational specialist, the occupational physician. So all these things has to do in some way with visibility and raise awareness on the important role of occupational medicine. And also because we got a progressive decline in the number of specialists in occupational medicine in many countries. And the average of the age of those that are occupational physicians is not very, it is quite old. Over 50, most of them. So this is something that must be changed. We must take action on this. There are a big number of questions, a big number of issues that we could discuss, we could get into debate, and unfortunately not be there at this Congress physically or personally, but to debate, but I will be in touch and also connected. And I must say to finish that present challenges and preparedness for future challenges that will come and future crises need an occupational medicine and occupational health strong, and they must be supported by three basic pillars of fundamentals, which is training, good training at different levels, undergraduate, postgraduate, and also continuous medical education, raise awareness, visibility of occupational medicine, occupational health, a collaboration, but not with words, with facts. We must collaborate, we must cooperate, and we must pull in the same direction from different universities, with different cultures, with different languages, from different associations, with different spirits, missions, and ambition, but because we all want a strong occupational medicine and a strong occupational health, we need to cooperate and pull, as I said, in the same direction. To debate on this and get bonds, links, and opportunity to foster cooperation, I want to invite to our most important room for joint activities and get together, which is the summer school. Next summer school, next August in 2022, will be in Belgrade, in beautiful Belgrade. And you will be very welcome, anyone from the audience that want to come and want to debate and create, as I said, partnership to move forward and get a strong occupational medicine. And after, we will celebrate our summer school in 2023 in Catania, Italy. Beautiful places, good colleague, and the best atmosphere to promote occupational medicine and to face all the challenges that we must face in every moment. So we wait for you. You will be very welcome. And I want to give thanks again to everyone this time for listen to this maybe long and boring talking about EASOM, but I hope can be inspiring to join us and get together, because together we will be strong. Thanks a lot.
It's a pity our thanks won't be online transferred there, but it is really empowering and delighting to benchmark these lists of learning goals and practices and the thinking beyond the education here. Unless there are burning questions, I would like to now invite Orion here, the representative. Tuulia Lipponen is there. Floor is yours.
Thank you. Kiitos ja oikein hyvää aamupäivää teille kaikille kuulijoille. Mä oon tosiaan Orionin edustaja Tuulia Lipponen ja toimin tässä Etelä-Suomen alueella. Mun vastuulla on meidän kipulääkkeet, antibiootit, psyykelääkkeet, vähän urologiaa ja gynekologiaa. Eli tervetuloa tuonne meidän standille hakemaan materiaalia ja keskustelemaan. Mutta katsotaan muutama kuva näin ennen taukoa. Aha, mulla on täällä ilmeisesti oma. No niin. Orionin kipulääkevalikoima on mittava, niin kuin hyvin tiedätte, ja tässä vain pintaraapasu siitä. Kaiken kaikkiaan sitä valikoimaahan löytyy aina paratapsista oksykodoniin asti, mutta näistä 4 haluan nyt teitä erityisesti muistuttaa. Eletriptaan-orion on meillä migreenipotilaiden hoitoon. Etorikoksib on viimeisimpänä kipulääkemarkkinaan tullut valmiste. Just ennen koronaa ehti tulla ja sitten sinä aikana on lisännyt kyllä suosiotansa kovasti. Sieltä löytyy laaja vahvuus- ja pakkausvalikoima ja varmasti jokaiseen vaivaan sitten lyhyempää tai pidempää kuuria. Alarivillä näkyy nämä meidän neuropaattisen kivun valmisteet, prekapaliin orion ja kaprion. Ja toki muistakaa prekapaliinin kohdalla ne muut indikaatiot, yleistynyt ahdistuneisuushäiriö ja tietysti paikallisalkuinen epilepsia näissä molemmissa. Antibioottipuolella erityinen huomio kiinnittyy tähän flukloxasilliin orioniin ihoinfektioiden käypähoito on juuri päivittynyt ja siellä on nostettu tämä valmiste ensisijaislääkkeeksi yhdessä sen laajakirjoisen valmisteen kanssa, kun puhutaan näistä kynsivallin tulehduksista, märkäruvesta, karvatuppitulehduksista ja paiseista. Ja tämän käyttö olisi todella hyvä, kun tämä kapeakirjoinen valmiste on. Me täällä Suomessa ollaan vielä vähän jäljessä, jos verrataan tuohon Ruotsiin, mutta kyllä tämän käyttö lisääntyy myös koko ajan ja se on tietysti hyvä asia. Tästä löytyy korttia tuolta meidän pöydältä, eli siellä on sitten vähän annosteluvinkkejä, kuinka tätä lääkettä voi käyttää, mutta tiheä annostelu on tietysti hyvä tämän kanssa. No sitten mennään sinne urologian puolelle. Sieltä erityisesti haluan ottaa esille eturauhasen hyvänlaatuisen liikakasvun ja 2 valmistetta sen hoitoon. Toki muitakin löytyy. Ja ensimmäisenä niistä tämä Tadalafil 5 milligrammanen vahvuus. Tässä pakkauskoot 28 ja 84 soveltuu hyvin siihen jokapäiväiseen käyttöön. Ja tämä helpottaa nimenomaan niitä virtsaamisvaivoja siinä eturauhasen liikakasvussa. Sitten sieltä löytyy tietysti 10 ja 20 milligrammaset vahvuudet sinne erektiohäiriön puolelle. No toinen valmiste samaan vaivaan on tämä meidän yhdistelmä Dutasteride Tamsulosiin Orion ja sieltä löytyy 30 ja 90 kapselia pakkaukset. Hinnat on tässä valmisteessa tullut ihan valtavasti alaspäin, että se, jos ei ole hetkeen niitä hintoja katsellut, niin varmasti hämmästytte, kun ne sieltä sitten katsotte. Sitten unen puolelta 2 muistutusta. Ensimmäinen on tämä Melatonin Orion, 3 milligrammanen on se meidän reseptivahvuus. Tuolla pöydällä on 1,9 milligrammasta itsehoitovahvuutta pitkävaikutteisena, mutta tässä tosiaan tämä reseptivahvuus ja tärkeää melatoniinin kohdalla on se oikea ottoajankohta, eli nyrkkisääntönä noin 1,5–2 tuntia ennen nukkumaan menoa. Ihan tarkasti, jos haluaa sitä laskea, niin keskiunesta 6 tuntia taaksepäin ja keskiuni on se nukahtamisen ja heräämisen puoliväli. Oho, meni väärään suuntaan. Ja sitten tämä toinen, eli Dormix, doksylamiini vaikuttavana aineena. Kyseessä on vanhan polven antihistamiini, jonka ainoa indikaatio on tämmöisen tilapäisen ajoittaisen unettomuuden hoito. Tämä auttaa nimenomaan siinä nukahtamisessa, jos se on ongelmana, ja tämän voi ottaa 0,5 tuntia ennen nukkumaan menoa. Ei vaadi sen suurempaa etukäteissuunnittelua tämän käyttö. Ja vaikutus on enimmillään 1–3 tunnin päästä. Semmoinen 8 tuntia olisi hyvä olla väliä siihen heräämiseen, että ei kovin myöhään sitten kuitenkaan. Sitten 2 itsehoitovalmistetta. Nämäkin löytyy tuolta, eli tässä on ensin naispotilaille tuoteperhe, josta löytyy 3 eri valmistetta. Femisan Vital tuolla alimpana on sisäisesti käytettävä. Pakkauksessa on mukana annostelija, jolla sen saa hyvin sinne emättimeen laitettua. Ja tarkoitus on kosteuttaa emätintä, limakalvoja siellä ja samoin sitten tasapainottaa sitä kohonnutta pH:ta. Femisan geeli on tarkoitettu ulkoiseen käyttöön kosteuttamaan ja suojaamaan intiimialueen limakalvoja. Ja sitten tämä Femisan Balance on tarkoitettu bakteerivaginoosin hoitoon. Ja huomatkaa, että kaikki nämä valmisteet tehdään Turussa. Nämä on kotimaisia ja tosiaan itsehoitovalmisteita, että ei sitä reseptiä tarvi. Sitten viimeisimpänä tuotemuistutuksena Colon Mint, joka on tarkoitettu niiden ärtyvän suolen oireisiin ja niiden hoitoon voisi kokeilla, jos tästä piparminttuöljykapselista olisi apua. Annostelu menee tosiaan noin, että 1 kapseli 1-3 kertaa vuorokaudessa alkuun ja sitten sitä voi vähän lisätä tarvittaessa. Ja mihin tämä vaikutusmekanismi perustuu, näkyy tässä, eli in vitro-tutkimuksissa on todettu, että tällä on vaahtoamista estävä ja ilmavaivoja lievittävä vaikutus ja vähentää myös sitä vaahdon määrää siellä vatsalaukussa ja suolistossa. Enteropäällysteinen, että vapautuu sitten siellä ohutsuolen loppuosassa. Sitten ihan lopuksi muistutus meidän omista sivuista. Esculapius.fi on osoite, johon pääsette Fimnet-tunnuksilla kirjautumaan. Ja täältä löytyy tosi paljon materiaalia, jota voi joko tilata ilmaisiksi sinne omalle vastaanotolle tai ladata ja printata ihan saman tien siitä koneelta. Sitten siellä on tietoiskuvideoita, jotka on keskimäärin semmoisia 6 minuutin mittaisia eri aiheista. Siellä on jo 20 eri videota alan ammattilaisten tekemiä, ei ole mitään meidän omia videoita siellä. Ja tietysti pääsee sitten perille siitä, mitä Orionille kuuluu, mitä meillä on tekeillä. Käykää ihmeessä tutustumassa, jos on tämä unohtunut. Ainutlaatuinen valikoima tosiaan meidän ja teidän käsissä. Orionin toimitusvarmuus on tällä hetkellä 99,3%. Kaiken kaikkiaan niitä pakkauksia meillä on kappaleissa melkein 1700 apteekkien järjestelmissä ja koronasta huolimatta ollaan onnistuttu jopa parantamaan tätä toimitusvarmuutta. Eli silloin kun Orionin lääkkeen reseptiin valitsette, on erittäin todennäköistä, että potilas myös sen apteekista mukaansa saa. Ja sillä, mitä te valitsette reseptiin, on tosi iso merkitys ja se on myös apteekissa helpottava tekijä. Silloin heidän ei tarvitse enää kysyä mitään muuta kuin, että haluatteko sen valmisteen, minkä lääkäri on kirjoittanut. Kiitos teille, oikein hyvää päivänjatkoa ja nähdään tuolla standilla.
Thank you, Tuulia, so much. Our morning session is still continuing after the break. We could do better with occupational hygiene. In fact, in Finland, there is already a working group considering possibilities of having a new textbook on this issue. So the topic is very important, and be back after nearly a quarter, at 11:15, and before that, enjoy a beautiful, nice coffee or tea, thanks to Orion. Okay, you are warmly welcome to continue our morning session. There will be a slight change in the program. After this presentation, we're having a tradition, a cérémonie protocolaire of this network. The Kuopio, the University of Eastern Finland team will have a short presentation after the next presentation. But now we have an online visitor. Are we ready? There will be a presentation on new trends in occupational hygiene by Professor Do-Young Park from Korea.
Good morning, this is Do-Young again. I'm pleased to meet you again today. And the title that I'm presenting today is New Trends in Occupational Hygiene. The new trends means the beginning of a new direction by exploring a new direction, or new trend comes by turning to a new direction, by changing or twisting something that already exists. And this one, so it starts something new, and then over time will become more normal before something else will become trend. So here, when does this new trend has come out? And I think that there are three reasons when we have the new trend. One is that new problems are emerging, and second was the problems are changing, and when circumstances are changed, we think the new trend. So we are facing the new problems, like a new health hazard, new type of work, and new type of workers. And problems are changed also, especially for the exposure profiles and exposure patterns. And lastly, circumstances are changed. We are facing advanced technologies. So as the new technology are available, we have to use that. And also this new technology raised the new health issues. And we found some limitations of the existing IH approaches, IH schemes. So to accommodate this new trend, we established the Asian network, ANOM, and also we are thinking about to develop new IH monitoring and checking system. And lastly, we are thinking improve or change some exposure limit set. So we established the Asian network to develop Asian ways, because in Asia, in many Asia, we have a lot of the new issues of in industrial hygiene area. And to accommodate the changes of the exposure patterns and exposure schemes, we are trying to develop a new IH monitoring schemes, monitoring systems, like the new services system for self-monitoring and real-time monitoring system, and simple checking system for the ventilation in office. And we try to develop the checklist or assessment tool for the work from home. And lastly, we thought we need to change some of the exposure limit scheme. Okay, so let me start from the establishing of the Asian network. As I talked just before, we tried to develop the Asian network because Asian situation, we have the lot of the IH issues these days, because in most Asian countries, we have the very short time economic development span, but it has been rapid growth. Therefore, there are a lot of issues in industrial health. So in many countries, in most Asian countries, we have increased demand for industrial hygiene. Because as you know, in most Asian countries, they have very huge population, China, Thailand, and in India, and also in Korea, Japan. And most Asian countries have a huge population, and so we are based on the labor-intensive work, actually, most countries. And in Asia, from the farming to the mining, coal mining, and the manufacturing, and even for the high-tech semiconductor industry, there's huge variety in Asian countries. Thus, we have a lot of the increased demand in industrial hygiene area. However, we are suffering from the lacking of experience and knowledge and techniques and tools everywhere, for everything in industrial hygiene. And also we are suffering from the lack of number of industrial hygienists, professionals. Overall, we are in the a weak infrastructure, I can say like that. Therefore, we can with this weak infrastructure, we were trying to protect workers' health from the health hazard, and we found some trial and errors for the last decades. And because we have tried to learn from the Western countries and the advanced countries, because they already developed some industrial hygiene technologies and schemes and knowledges. And we found some fault from those things. Because I'd like to explain with this Liebig's law. This is good to explain that. Liebig's law means the plant growth is controlled by, not by the total resources available, but by the scarcest resource. I call it limiting factors. And this Liebig's explained with this Liebig's better. The water level is determined by the shortest panel. That is to explain the law of minimum for the plant. I think this theory can be directly applied to the occupational safety and health, especially for the occupational health, actually. The overall OH performance is generally achieved not by the total of the resources available, but by the scarcest resource or the high exposure, the limiting factor. So the water level, if you increase the water level, if you increase the total health, then you have to make up the shortest panel. You have to change or you have to block the shortest one. Otherwise, in the past, in many the Asian countries, we want to make the improve by adopting the best practice like this. From the large companies or from the advanced countries, we want to introduce the high technology or the best practice in our workplaces or in our system, in our country. And we found that this doesn't help actually. These are some limitations because the system, if the whole system doesn't change, then one or two best practices doesn't work to protect workers from the accident or the occupational disease. Therefore, in early in the 2000s and 2010, we talked about how to develop the industrial hygiene in Asian area. And officially in 2010, in Rome, in Italy, we had done some informal talk to build an organization of Asian network. And 2012, in IOHA conference in Kuala Lumpur, we had a round table to discuss the establishment of the Asian network. And there was a huge talk because we found that it was some difficulties to make international organization in Asia because in most Asian countries don't have the association yet at the time. So it is impossible to make an association of association. Actually, industrial hygiene, International Occupational Hygiene Association is association of association. But in many Asian countries, they don't have the association. Therefore, it was not easy to make the international or the regional association. So in 2013, we discussed again in the committee, and in 2014, early in 2014, we had the committee meeting and the second committee meeting in the September 2014 to discuss the draft version of the governing system and bylaw and the structure. And finally, in 2014, we launched the Asian Network of Occupational Hygiene. And we had a launching ceremony in Kuala Lumpur in November. And 60 countries, a huge number, 60 countries are participating. And we had a mini conference. And everybody would love to make a network to develop our own ways. And in 2015, after that, we had a board meeting and another board meeting in 2016. And in 2016, we had the first official annual conference in Hanoi, Vietnam. And it was quite successful. And the second conference was held in the Guangzhou in 2017. And it was also the fantastic. We enjoyed to discuss for the future in industrial hygiene area. And the third conference was held in Taipei, Taiwan. And it was also quite successful and very fruitful. And in 2019, the fourth conference was held in Bangkok, Thailand. But in 2020, we couldn't have the conference because of the COVID-19 pandemic. And here, in the Asian network, we thought a lot and we discussed a lot for the IH monitoring and checking system and exposure limit. And some of the idea was just idea, and some of the idea was the realized and implemented. And even though it is in the pilot system or in the experimental lab. However, during the COVID-19, we realized that it was correct. The way was correct. So I'd like to share what we have done so far for the new IH monitoring or new industrial hygiene checking. The first one is like this. I'd like to start from just review the industrial hygiene definition. As you know, the industrial hygiene was defined as a science and art to protect workers' health from health hazard. And the main principal methodology is the anticipating, recognizing, evaluating, and controlling for health hazard. And there are 5 categories in the traditional health hazard. The first one is a physical health hazard. That is the exist in energy form, the noise, vibration, radiation, like that. And the second category is a chemical health hazard. That is exist in the substantive form, in the gas or the liquid or solid form. And the biological health hazard is well known during the COVID-19, like a virus and the bacteria and fungi. And the fourth category is a physiological health hazard. There's a physiological overburden, work burden, like ergonomic factors or low back pain problem, or musculoskeletal disorders. And the last one is a psychological problem. There's a mental health, mental work burden. And this is also well known, the web of causation. To cause the occupational injury and illness, there is a direct cause. Direct cause, behind the direct cause, there are a huge number of the indirect causes. If we do the investigation again and again, then we can find a huge number of indirect causes. And also in the background, there was culture and also the economic structures like that. However, to prevent the accident and the occupational disease, we have to control the critical point. That's a direct cause, and direct cause in industrial hygiene, that is the exposure actually. Without exposure, there is no occupational disease. There's a basic concept. And I think one of the greatest invention in industrial hygiene, that is the permissible exposure limit. From this concept, we can quantify and qualify the health hazard. And for this traditional health hazard, there are a lot of methods to scientifically quantify. Without the measurement, it is difficult to manage those health hazards. So there are a lot of the commercial products available for the measurement or checking or sampling analysis. And this one is based on this concentration profile. This concentration profile means assuming the similar exposure group, then if you collect a sample, then we can measure the mean value and the variation. From this data, we can make a statistical judgment to assess the high exposure risk group, or some workers or some measurement that is exceeded the permissible exposure limit. However, this traditional sampling and analytical method has some limitations because the exposure patterns, exposure profiles, concentration profiles has been changed. In the past, we are assuming that the stable and the static conditions. So if you do the measurement once a year or twice a year, then it is believed that those measurements are representative for those groups. However, these days, the exposure patterns has been changed. In many countries, even in Asia, the average concentration is quite low because the plant condition is getting better and better. However, some workers, and sometimes they are exposed at a very high concentration. It's like a spot exposure or peak exposure. And using this traditional method, it is very difficult to do the measurement for spot or high peak exposure, even though we have the short-term exposure limit or peak exposure limit, but practically, reasonably, with this integrated sampling and analytical method, not very well work for the high exposure, the irregular exposure. Therefore, to evaluate high exposure, high peak exposure, we thought we need to apply the continuous monitoring system or real-time monitoring system to reflect that. And not only to measure, to make them consultation on time to avoid the high exposure without it is necessary to do the real-time monitoring. That's why we developed new ways to overcome these limitations. That was the first one is one of the examples. We developed assessment system for the self-personal monitoring to a chemical exposure. The idea is this one: self-monitoring, self-personal monitoring. That means workers by themselves or employers by themselves, whenever, wherever, or whoever, if they want to do the monitoring, they have to have some method available. And the traditional method was provided by the professionals, IH professionals. But for this kind of the passive sampler, it's very simple. Just open the lid and attach the sampler and the collar. Then the samples are collected. Okay, and if just they write the sampling time, starting time and the ending time, then that's enough. Of course, if there is information on the chemicals and process, that is the better to analyze. But if we have some experience when we develop this system, if they are asked the personal information and workplace information, they are not willing to take the samples at the high exposure time. because they are worrying about the inspections by the government or penalty or disadvantages. Therefore, we developed this system based on the blind monitoring. Blind monitoring means we do not collect the personal exposure. We do not collect any information of the workplaces, the industry. So we just distributed these samples, these samplers to the workers and to the employees. And we encourage them to take a sample when they think that when they are exposed at the high concentration or anytime they have concerns. And in the backside of this passive sampler, there's a QR code. We attach the QR code. So if they take the picture of the QR code with a smartphone, that's all. And they send sample to us. Yeah, then we developed some automatic analysis system for this sampler because we expecting that it will be the huge number of samples from the industry or from the workers. So we developed the automatic analytical system using the GC-MS and the gas chromatography. If we put the sampler into the system, then this system is automatically analyzed. And there is some library, chemical library spectrum. Using those chemical library spectrum, this instrument quantify and qualify the chemicals. Not everyone, for the most popular chemicals in the workplaces. So this is not just general use. This is for the general use. Okay. And after the analyzing, this result is with the QR code just shown on the website automatically. So worker, after the 2 days later, the workers just check on the website with the QR code, and they can be provided the rough information, high above the PEL or below the PEL, or looks okay. It seems that's very dangerous. If it is dangerous, red zone, they are located in the red zone, then it is highly recommended to double check, or please ask us, then we can help them. So this is the for self-monitoring for the self-management, because we cannot access the workplaces at the right time. Sometimes they have the maintenance, but because of the system was broken. Then the sampling for that time is not available for by the professionals. We cannot access right time. That's why we developed this one by themselves. Whenever they want to check, we thought the system should be available. This is the what we developed that on, and for last several years, it was quite successful. The concept was realized, and it was implemented, and we got a very good feedback actually. And we have to several the issues to resolve the technical problems, but for very typical chemicals, it worked actually. And also, we developed a real-time sensor. Here, this is the sensor kit. Inside there, there were several sensors actually, PID and semiconductor sensors, and there's the communication chip, 5G using chips for the send signal, and the Wi-Fi is also available if there's a Wi-Fi connected. And we distributed this one to the industry to install these sensors in their workplaces wherever they want. And if they turn on this switch, then signal is collected to our server system. And in our server system, we set some program. So the concentration profile is getting higher, and it is exceeding at a certain level, certain setting. Then alarm signal is go directly to the workers through the smartphone or the computer. And we found this very interesting things during the pilot test. Nobody knew that the high exposure after the shift, and there was no smell, no odor. So they thought there was no problem. However, using this combination of sensors, we found some problems and we send the feedbacks. Actually, the server system, computer system, send the signals, and they asked us to make some investigation at the site. So this one is very good to make the cooperation with the industry. And also, it is good to avoid the high exposure because the exposure signal is sent directly to the workers right away after the exposure. And this is another example. That is the simple tools for the ventilation. And which we developed a checklist on the website, the room size, window openings like that. And then the workers or the employers, they check the room size, they input the information on the website. Then right away, the evaluation result of the ventilation is shown on the website by some program. Lovely. It's not exact. So if based on this information, the ventilation is very poor, then it is highly recommended to contact us. Then we send the CO2 monitor, and this is the Wi-Fi connected, and also the 5G communication chip inside there. So the signal is sent to us directly if they turn on this one. So they put on this one on the table in the office. Actually, this is the to block to reduce the COVID coronavirus, to block the COVID-19 transmission during the COVID-19, because the office in some office area, like a call center, there's crowded workers, and they continue talking during the talking or the conversation on the phone. We are worried about the transmission of the virus. So if they install this, put this CO2 monitor, then right away the CO2 concentration is collected in our server system, and we can make a judgment whether it is okay or not, and when they should open the windows like that. This is another service, and that was quite good feedback. And lastly, we thought about we thought that we needed to change the exposure limit setting. Current exposure limit is based on this one, and newly emerging issues like the ergonomic issues and the mental stress, there is no very limited exposure limit. Without the exposure limit, it is very difficult to make an engagement, involvement, or judgment. So somehow that is our new challenges. Although there is some exposure limit is available for the ergonomic factors, but still we have no universal exposure limit. And we think the emerging issues like the working hour and working shift, that is also the health hazard. Therefore, somehow we have to prepare the exposure limit for the working hours and working shift. In the past, it was considered as a field of work standard. But even though this working hour and work shift is a satisfied work standard, however, in the viewpoint of the occupational hygiene, to protect the workers' health, the working hour and working shift, that should be included as the health hazard. Then we can develop some other ways. Lastly, currently, we have the exposure limit scheme based on the single value for the TWA or PER. Even for the STEL, there's a single value. For example, like this, chemical A, let's assume the chemical A and chemical B. The measurement is artificially 30 ppm. Let's assume that. And both have the same permissible exposure limit of 20 ppm. If we have the different permissible exposure limit scheme like this, 3 levels. not only the 20 ppm. Here's the 50 ppm for chemical A. That's the allowable exceeding limit. Maximum allowable exceeding limit is the 50 ppm, and the desirable limit is 10 ppm. And for chemical B, maybe different. Maximum exceeding limit is 25, and the desirable concentration is 15. Then this 30 ppm, the position is between the 50 and the 20. So they can make a judgment how dangerous it is, And for the chemical B, this is the above the maximum value. Therefore, it is dangerous. So professional can judgment with a single value. However, the employers and employees, they need more detailed information. So if we provide the different levels of the exposure limit, then it will help the employers and employees to make the precise judgment. It's a better judgment, actually. And also, for the same chemicals, let's assume that the permissible exposure limit is 10 ppm, and the exposure result is for worker A, worker number 1, that's a 15. Number 2 is the 4 ppm. So 15 ppm is above the 10 ppm, 4 ppm is below the 10 ppm, right? But if you provide these 3 levels, then 50 ppm is between here somewhere, and 4 ppm is quite below than the desired one. So it's quite okay, right? So they can make the judgment. And lastly, instead of the single value, if we provide the statistical variables for the exposure limit, like the geometric mean and geometric standard deviation, then to make a judgment, they have to take the more samples rather than the single. For more people or for the single workers, they have to take the more samples along the time. Then they can make the precise judgment. And I believe it is encouraging to take the more samples. Or if you provide a 95 percentile value, then to make the judgment, they have to take the more samples because we need the geometric mean and geometric standard deviation to calculate the 95 percentile values. So this is what we are thinking. And for the work from home, we try to develop some guidelines and assessment tool because it was highly encouraged to do the work from home during the COVID-19. And we found some problems. So some workers cannot do the work from home due to the several problems, like their condition, home office condition was not appropriate. And also, the company has to have the program for the management, how to manage, how to supervise, and how to do consultation for the workers for work from home. And some work task is appropriate, and some tasks or some work is not appropriate for the work from home. So they need to separate the work time and personal capability. Some workers are like the work from home, and some workers don't like. Or personal skills to manage the schedule or time. So it depends on the capability of the workers. It should be properly managed. So we try to develop this one, and we did some pilot test, and it was quite useful for the industry. And this is conclusion. So the key words of changes, as I think, as I talked to yesterday, the increased irregularity and the mental health problem, and also the technology. Those kind of things is a lot of changes of the keywords, and we have to develop the new ways. That's why we developed the Asian network, and we have considered developing the new monitoring systems and the new exposure limit setting. Thank you very much again. I appreciate for you inviting me to share what we are thinking in the Asia and Korea. Thank you very much.
Again, it would be so nice to thank for this very educative presentation in person. Jorma, you would like to thank.
Thank you, Du Yong, for excellent presentation. I would like to tell you something about the occupational hygiene in general, and then refer to Du Yong's perspectives. We are working very closely together, and we have been together in the Southern Pacific to help the small island countries in occupational hygiene, and he has been really marvelous MacGyver in those activities. Du Yong, I want to tell you that Du Yong is not only occupational hygienist, he is also president of KOSHA, which if you put the Finnish Kela accident insurance companies and pension institutions of Finland together, it's KOSHA, having something like 20,000 staff members. Yes, also, yes, Finnish Institute also. And strong laboratories, enormous program for occupational health services, also for small-scale enterprises. They have 35 centers for occupational health services for small enterprises. Korea started to be really the leading country in Asia and in the world for particularly occupational hygiene, and soon also in occupational health services. This is one point. Secondly, what Du Yong has done, he has also been involved with the identification of new occupational diseases on the basis of his very strong scientific background. He is one of those who identified the indium lung injury, which you may not have heard at all. It is the sweep screen mechanism which is transmitting the electronic pulse from the glass surface to electronic system, and the indium metal is that which is transmitting it. It's extremely toxic. It is practically destroying your lungs, and they have in Korea several cases of that kind of lung injury. So just to tell about his impact. But why I asked for floor, it is more, let's say, mielensä pahoittajan comment. Occupational hygiene is very important for occupational health because it is giving the exposure background for everything what we think. It is also extremely important for epidemiology because, in fact, you cannot make epidemiology if you don't have exposure data. We need that, and it should be measured, objective, no just opinion like in control banding systems are done. It must be measured, documented, and all. And what Du Yong, in his leadership, is now happening. As occupational hygiene in Europe is going down, it is going also down in US. Asia seems to become the leading country or the region in occupational hygiene. And what is now the key, what he also demonstrated? They are making portable, objective, high quality, accurate measurement systems which you can simply transfer in your pocket. And we have discussed with Du Yong about small A4 size briefcase where we have practically everything what can be needed for measuring exposures at the workplace, including, for instance, 50 different chemicals. Noise, air velocity, dust, lighting, and so on, radiations. And this basket would probably cost something like 15,000 euros. And you could go to workplaces and measure. And why I partly wanted to comment this is that now when we are growingly moving to telework and distant work, homework, also there are hygienic problems. which should be measured and documented and also prevented and controlled. And what he just demonstrated, this is the way to do also home occupational hygiene, which is really the future perspective for occupational hygiene. And now my final comment is that Finland is seriously going down in occupational hygiene. And we should really do something to keep it, because still, for instance, European workers in 30% are exposed to chemicals. But we don't anymore. So thank you. My mielensä pahoittajan kommentti.
Thank you so much. This is important, and also in terms of it's an important message for us that we as occupational health physicians make sure that we have access to those workplace visits, that it's not totally transferred to nurses who essentially lack any education on these issues. Their education is different. So we need to have people who know about these things to go and visit the workplaces and organize this hygienic surveillance to be able to interpret for the main purposes. Thank you so much. She's taking one, and then we're having team University of Eastern Finland here.
Jorma, if you know Professor Park so well, so could you please send our regards to him, because there it has come a lot of comments, and the humble Korean attitude towards problems, how to take them and do the actions and not hide them under the rug, has produced very much praise in the, and the other one, his 4 screens got a lot of mentions, so please send him regards. Positive mentions, a lot of admiration.
He wanted to come here, but unfortunately it's now not possible, but he will come soon.
Yeah.
He will make use of it.
I'm also sure that the working group who is preparing probably, or at least considering possibilities for having a textbook here in Finland, seriously listened to this beautiful presentation. Thank you so much, Ben. Now I'm inviting to the stage Jarmo Heikkinen from University of Eastern Finland.
This seminar is yearly, and it goes from Finnish university to another. And next year, we have a pleasure to go to beautiful Kuopio in Eastern Finland. And on the behalf of University of Helsinki, we pass this baking pin, which is kind of baton to give further to Kuopio. You can write University of Eastern Finland there and then take it further. It's a new tradition.
Joo, kiitoksia viestikapulasta ja hyvät ihmiset, tervetuloa Kuopioon sitten ensi kesänä. Että meillä on keskisen Suomen kaunein kaupunki, Järvi-Suomen kaunein kaupunki siellä ja meillä on hyvät aiheet, meillä kaikillehän se on silleen tuttu, että kaikki työpaikkalääkärit niin tuijottaa näyttöä joka päivä ja räpleivät koneetta, mutta me koitetaan vähän tieteellisempi näkökulma ottaa kuitenkin asiaa. Sitten meillä on kulttuurista hyvinvointia, on siellä tanssii ja soi viikko seuraavalla viikolla, että joka haluaa pidentää olemistaan siellä Kuopiossa ja naatiskella elämästä, niin siinä voi ottaa sitten semmoisen vähän pitemmän seminaariloman sitten ensi kesänä. Mutta olette kaikki tervetulleita ja koitetaan pitää hyvä seminaari ensi kesäkuussa, siis poikkeuksellisesti jo kesäkuussa. Ja kun tulette, niin ottakaa vielä kaverikin mukaan. Tervetuloa.
So this happy family of occupational healthcare medical specialist education will meet in half a year in Eastern Finland. Thanks for all the presenters and the audience for this morning session. We are next having lunch and enjoying company and the exhibition. And we are continuing at 1:45. Stay tuned.
Joo, laittaa mikin päälle. Hyvä. Hei vaan kaikille. Orionilta voideterveiset. Tulin teille kertomaan, eli olen Petina Tapanainen, lääkeesittelijä, toimin tässä alueella ja Länsi-Helsinki, Länsi-Uusimaa ovat alueitani. Ja käyn tapaamassa työterveyslääkäreiden lisäksi terveyskeskuslääkäreitä ja ihotautilääkäreitä ja lastenlääkäreitä. Että nämä on ne minun kohderyhmäni ja paljon teen näiden ihotautilääkäreiden kanssa itse töitä myöskin. Ja Orionihan on sellainen firma, joka on vuodesta 1953 tehnyt jo voiteita ja ensimmäisiä tuli sitten 70-luvulla tuli nämä voiteet apteekkiin myyntiin. Sitä ennen me oltiin pelkästään sairaaloissa. Ja jos joku tietää, että perusvoiteitahan se on tämmöinen niin kuin pohjoismainen konsepti. Ja yhdeltä työterveyslääkäriltä kuulin tällaisen asian, että hänellä on työntekijä, joka on puolet vuodesta Intiassa ja puolet Suomessa. Ja kun hän on Intiassa, niin hän ei tarvitse perusvoiteita, mutta kun hän tulee Suomeen, niin sitten se käyttö alkaa. Mutta mennään eteenpäin. Eli eri vuodenajat vaikuttaa ihoon. Varmaan osa on huomannut jo, nyt kun alkaa kylmenee ilmat, niin iho kuivuu eri tavalla. Kesällä meillä on iho paremmassa kunnossa ja silloin kannattaa valita ne voiteet sen ajan mukaisesti. Ja aurinkovalo on sellainen, joka meidän ihoa hellii ja tämmöinen kuiva ja kylmä ilma sitä kuivattaa. Ja sitten talvisin kannattaa käyttää niitä vähän kosteuttavampia voiteita. Ja perusvoiteissa on hyvä suosittaa näitä tämmöisiä hoitopareja, varsinkin kun aika monella meistä aamut tahtoo olla kiireisiä, niin silloin on hyvä, kun on semmoinen voide, joka imeytyy nopeammin ja kosteuttaa ehkä ei niin hyvin, mutta sitten ilta-aikaa voi laittaa semmoista hoitavampaa voidetta, joka saa rauhassa imeytyä. Tässä on ihan tämmöisiä esimerkkejä, eli mitä voisi aamuisin käyttää, niin Aqualaan L, Duo tai Plussaa, ja iltaisin sitten näitä vähän hoitavampia voiteita, eli Seralaan Plussa, Karbalaan ja Karbalaan Plussa, ja sitten tämä meidän uusin voide Propicare, joka on tämmöinen probioottinen voide. Ja sitten jos on kuivia paikallisesti kohtia, niin siellä on hyvät Novalaan, Lipolaan voiteet, että nämä tämmöiset niin kuin rasvaisempia voiteita, jos on parafiinia tai muita valmisteita. Ja tärkeää on se, että perusvoiteita käytetään oikein, eli voidellaan puhtaalle iholle ja sillä tavalla, että jos sä oot aamulla laittanut perusvoidetta, niin käyt suihkussa ennen kuin laitat sen iltaperusvoiteen. Ja varsinkin atoopikon iho täytyy pestä usein. Kaikki tämmöiset hiet, liat äkkiä pois atoopikilla, ne aiheuttaa sitä kutinaa ja ihon ärsytystä. Käsivoidetta käytetään aina käsinpesun jälkeen, ja jos tuntuu kirveilyä, että se voide kirvelee, niin kannattaa sitten vaihtaa vähän rasvasempaan voiteeseen. Ja kun tuutte suihkusta, jättäkää iho lievästi kosteaksi, koska se voide liukuu paremmin, se imee sitä kosteutta sisäänsä ja se on helpompi levittää. Ja voiko perusvoiteita käyttää atooppisessa ihossa hoidoksi? Kyllä. Eli perusvoiteet jaotellaan kahteen ryhmään, tämmöiset tavallisemmat perusvoiteet, jotka on tämmöisiä niin kuin ehkä kevyempiä, ja sitten on nämä ihoa kosteutta sitovia aineita sisältävät humektantit, eli ne sisältää joko karbamidia, eli ureaa, tai sitten glyserolia tai propyyleeniglykolia. Ja nämä on semmoisia kosteutta hyvin sitovia aineita. Ja lievässä ekseemassa voi olla ihan pelkästään, ja sitten tuommoisessa keskivaikeassa ja vaikeassa, niin sitten sinne lääkevoiteiden kanssa. Ja se kannattaa muistaa, että lääkevoidetta ja perusvoidetta ei käytetä samanaikaisesti, eli tunti ainakin mielellään sinne väliin. Koska muuten se huippupitoisuus, mikä saavutetaan lääkevoiteesta, niin se jää saamatta, koska se perusvoide laimentaa sen. Eli vähän sama kuin laittaisi käsihuhteen päälle vettä. Ja ne, mitkä on parhaiten tutkittuja näistä perusvoiteista, on nämä ureaa, eli karbamidia sisältävät voiteet, eli meille Karbalaan ja Karbalaan Plussa. Ja säännöllisesti atoopikolle perusvoidetta, vaikka se iho olisi paremmassa kunnossa. Ja näistä meidän keramidivoiteista meillä on 2, eli Seralaan ja Seralaan Plussa. ihmisellä iho sisältää noin 6 keramiidia, ja Seralaanissa on 1 keramiidi, ja Seralaan plussassa on 3 keramiidia. Ja nämä on hyviä voiteita käsiihottumiin ja yleensä tämmöiseksi niin kuin kosteuttaviksi voiteiksi, mutta Seralaan plussa on löytänyt tiensä lastenlääkärien sydämeen, eli tätä käytetään paljon atooppikkolasten ihonhoidossa. Ja sitten kun puhutaan näistä karbamiidivoiteista, joita on eniten tutkittu, niin meillähän löytyy 2 valmistetta. Ja nämä sisältää tosiaan 5% karbamiidia. Jos mennään yli 5%, sinne sanotaan yli 10, niin silloin se on jo kuoriva se karbamiidi. Ja nämä on helposti levittyviä ja hajusteettomia, kaikki niin kuin Orionin voiteet. Ja Karbalaanissa on kevyt voidepohja ja Karbalaan plussassa on keskirasvainen. Ja sen lisäksi, kun niissä on se karbamiidi, niin ne sisältää tämä Karbalaan plussa niin glyserolia, karitevoita ja sitten sitä ksylitolia. Ja nämä on erittäin hyviä atoopikon ja sitten psoriaasiksen hoitoon. Ja mitä tässä on, niin karbamiidi tosiaan on tämmöinen tehokas kosteuttaja, se ottaa sen kosteuden oikeastaan mistä vaan. Ja sen takia me ei suositella näitä alle leikki-ikäisille lapsille, koska ne saattaa sitten kirveltää, kun sitä kosteutta otetaan. Glyseroli on hyvä sitomaan myöskin kosteutta. Karitevoi on tämmöinen kasvisrasva ja se pehmittää ihoa. Sitä löytyy aika paljon näistä naisten kasvo- ja partalokosmetiikasta. Ja ksylitoli on tämmöinen kosteuttaja, mutta se myöskin hillitsee kutinaa. Eli yhdessä glyserolin kanssa ne madaltaa tämmöistä meidän ihon suojakerroksen läpäisevyyttä, eli transepidermis water losing arvoa. Ja mitä matalampi se on, sitä vähemmän iho läpäisee kosteutta. Eli tämä on hyvä niille ihmisille, varsinkin joilla on atooppinen iho. Ja kun puhuin tästä Propikeeristä, meidän viimeisimmästä voiteesta, niin Propikeeri on tämmöinen ensimmäinen probioottinen perusvoide. Ja me tiedetään näistä probioottisista voiteista, että se pitää sen oman mikrobiomiston mahdollisimman monipuolisena ja näin vaikuttaa sinne immunopuolistukseen ja suojaamiseen, ihon suojaamiseen. Ja meillä on tosiaan tässä meidän Propikeerissä on Lactococcus lactii-soluutetta, sitten löytyy glyseroli, karitevoi ja butyleeniglykooli. Ja kaikki meidän voiteet tehdään Suomessa ja kehitetään myöskin täällä. Ja tässä ei ole eläinperäisiä aineita ja tämä on myöskin hajusteeton. Tämä on hyvä tämä meidän kattava voidekartta. Tästä löytyy kaikki nämä voiteet ja kuinka paljon niiden voide kautta vesi- ja rasvasuhde on. Ja voidepesuoppaita löytyy tuolta meidän standilta, jos joku haluaa jakaa näitä potilaillensa. Myöskin muuta potilasmateriaalia meillä on saatavana. Nämä kaikki on ruotsinkielisenä, löytyy, eli atooppisen ihottuman hoite, voidepesu ja noin voidevinkit. Ja sitten nämä löytyy suomenkielisenä yhteistyössä Astma, Allergia ja Iholiiton kanssa tehdyt käsiihottumaopas. Ja sitten tämä meidän viimeisin uusin, tämä intiimialueen jäkälöitymissairaudet. Ja näitä voi sitten pyytää oman alueen edustajalta, jos on kiinnostunut tai on näitä puna- tai valkojäkäläpotilaita. Ja ehdottomasti suosittelen meidän perusvoide.fi-sivustoa. Sieltä löytyy kaikki asiat yhdestä osoitteesta. Eli sieltä löytyy tuotteista kaikki, mitä haluatte tietää, valintaoppaat, sieltä löytyy myöskin voidevinkkejä ja näin talveen vasten esimerkiksi niin talvi- ja atooppinen iho-artikkeleita. Aikaisemmin sai käyttää PIH-lyhennettä, mutta nyt Kela toivoo sen, että siellä lukee pitkäaikaisen ihotaudin hoidossa. Yleensä nuo farmasistit avaavat kyllä tämän, jos se on reseptissä löytyy, mutta ajatuksena on se, että tämä kirjoitettaisiin sinne. Ja Kela korvaa sen 1,5 kiloa kuukaudessa. Kaikki perusvoiteet yhteenlaskettuna. Ja tuossa näkyy noista hinnoista, eli huomattavasti on etua siitä, jos potilas tarvitsee perusvoidetta, että sen kirjoittaa reseptille. Ja tässä on muistutus siitä, että meillä Orionilla tehdään Suomessa lääkkeitä, mutta myös voiteita, ja Turku on se paikka, missä me valmistetaan meidän kaikki voiteet ja perusvoiteet ja kortisonit. Kiitos. Olisiko kysyttävää? Jos ei, niin kiitän ja päästän teidät jatkamaan ohjelmaa eteenpäin. Hyvää päivän jatkoa ja tulkaa käymään vielä standille. Kiitos.
Okay, good afternoon. We have still a couple of minutes time, but we discussed that probably we are all here who wish to participate in the next session, so we will continue our program. And I wish you all very welcome to this session number 4. Where we will discuss about the future trends in occupational psychology and ergonomics, as well as the challenges of future work on occupational safety and health. Our first speaker, Minna Huotilainen, works in the University of Helsinki as a professor of educational sciences. I hope that was the correct. Thank you. She has done a lot of research in the field of memory and learning, and she is the leader of the master program of changing education. And she is a very popular and famous speaker when the topic is related to brain and work. The title of Minna's presentation today is New Trends in Occupational Psychology. Please, Minna, the floor is yours.
Thank you, and good afternoon, everybody. It's wonderful to be here to talk a little bit about my own work and the work in this field. So I have a work experience also from the Finnish Institute of Occupational Health, and that was in the early 2000s, and that gave me a kind of a view also to the Finnish work life. And my background is in neuroscience, so neuroscience is the method that I am using in these studies. Okay, if we think about what work-related neuroscience can actually bring to work well-being, many of the studies are kind of artificial because they are done in the brain research laboratories, and what you actually can do with these devices is you have to have a work simulation, so you have to separate a kind of a piece of work that is of interest to you and study it in isolation. We have studied, for example, interruptions and jumping from one task to another, and how that is activating the brain, and how the brain is also becoming exhausted after jumping from one task to another. But obviously you cannot bring these devices to the workplace. But the world of neuroscience is changing really quickly, and we see also devices that can be used at workplaces. And one of them is the famous old electroencephalogram. This is probably one of the oldest brain research methods, invented already 100 years ago almost in Germany. But I think that it is also a method of the future because it is portable. It's a small device, smaller than a mobile phone. And in addition to the small device, you also, of course, then need this cap where you have the connections to the surface of the head. In this picture, we are studying the work of the teacher. We are measuring teachers' and pupils' brain activity during a normal school day. So you can imagine how holistic this is. There is the task that is given to the pupils, but you can imagine that so many other things are happening at the same time. There's maybe some noise and somebody wants to say something to the teacher and somebody's asking for help and somebody's dropping his pen on the floor and so on. So in this kind of way, we get a much more holistic view of what actually constitutes the working day. And I think this kind of approach is really important because for our brains, it's not only the tasks that are demanding, but it's everything else too. The working environments, the background noise, the interruptions, the social aspects, and so on. Then there's another trend also for measuring work, and this is called quantified self, or you could say quantified employee. When people are wearing these measurement devices throughout their working days and also maybe during their leisure time and also at night, and many of these devices are capable of recording electrocardiogram, but they are not meant for studying the heart. They are meant for studying stress levels and physiological reactions in the everyday life. Many of these devices are meant for consumers. They are very popular, especially in Finland. And if you have people working in technical fields, for example, people with academic education, you very often see them wearing some of these devices. It could be an Oura ring measuring cardiac activity and interpreting that into stress levels, or it could be a wrist-worn device for the same purpose. Many of these companies are from Finland. It's not a coincidence, we all know why it is. It is because Nokia was heavily developing these technologies and then had to lay off a lot of people who then went and started their own companies. So we have dozens and dozens of these companies, and some of them are very, very successful. Oura and Firstbeat, one of those most successful ones. And the idea here is to look at heart rate variability. So how does the heartbeat vary from one beat to the next beat? And there is some theory behind this, and there's also some data behind this showing that the more stressed you are, the more regular is the heartbeat. So the heartbeat variability goes down if you feel very stressed. Heart rate also often then goes up. There are still things that are unclear. How does physical activity affect this situation and so on? So it's not completely straightforward, but these devices are very popular, and you might bump into data collected by the patient himself showing you that, okay, I have this kind of problem. Look at my data. It's completely visible here. I have a sleeping problem, or I'm very stressed, or something like that. That's a challenging situation, because how do you know about the reliability of these devices? How do you have access to the data? You have the mobile phone screen of the patient showing you his data, and then you have to figure out what is that data worth actually. I think this is a direction that is heavily taking over right now. So people are really thinking, the device manufacturers are thinking, the users are thinking, and also the medical community is thinking, what should we do with this data? Because it's not useless, but it's also not directly usable either. So we are still kind of in a mid-phase of finding solutions to this. And it's also a question like, whose data is it? Who owns the data? What if the device, the Firstbeat device, was given by the occupational health center? Or if the patient himself went to a pharmacy and bought this measurement? So does that make a difference? There are these types of questions still open in the field. But I think we cannot ignore these devices and the data that they are producing. I have used this U-curve to explain to people how these physiological responses can be interpreted into mental states that people know well. So here you have, I'm sorry, this is in Finnish, so here you have in the upper part of the picture very active states, and in the lower part more passive states, and on the left you have negative emotions and negative situations, and on the right you have these positive, more positive emotions. So probably the best known state of this physiological state is this fight or flight state, which you have in the upper left corner. This is an alarming state where the worker feels really threatened. It can be threat of violence at the workplace, but it can also simply just be too busy days, too many things to remember, too many things to do at the same time. People usually recognize how this state feels. Your heartbeat goes up, your blood pressure goes up, you start breathing very quickly, and so on. And of course, this is really stressful also for the body, and we cannot have this kind of state for a very long time. It's very exhausting. If it continues for a long time, you start seeing the person fall into more passive states, which you can see in the lower left corner. You can see fatigue, you can see tiredness, symptoms of depression, and so on. And this state is the gate to work fatigue. So before this worker becomes really ill, we have to do something to stop this kind of physiological states. On the right side, you also have some famous state, the flow state in the upper right corner. This is when people feel that they are doing so well at work and everything is so interesting, and they forget to have breaks and so on. And you can also have some consequences of that. On the right side, you also have these blue states, drowsiness, feeling really peaceful, being able to recover from your work. And these are very, very important states, obviously. Everybody needs those states, and we have to be able to guarantee those, hopefully during the working day, but if not so, then at least after the working day. These states are actually part of the Finnish culture. You know, we are very good at this. We have the summer cottage, and it's very peaceful there, and we go to sauna, and it's so peaceful, and it helps us recover. And we go and pick berries and mushroom and all that stuff. But then if you start critically thinking about a typical work week, how many Finns actually go to the forest and pick the berries? Most people just run around between their workplaces and their children's hobbies and their elderly parents' needs and all that stuff. So then, even if it is part of our culture, we also have to make time for it, and we have to appreciate it. I think this U-curve is a nice, simplified visualization of these physiological states, and it's a good question for a worker to actually think about which of these states are typical for you during your typical working day, and why. The big question, of course, is why, and what could you do to be able to move to the right to those green and blue states in this figure. We are in the middle of changing work spaces. So there's a lot of pressure, of course, to save money from the workspaces, and many employers think that, okay, we can pack people into smaller spaces because many people now like to work at home and so on. And sometimes all of this activity ends up to be like this picture on the left. I guess this is from the 50s or something, but we see workspaces like this coming up again. So nobody has their own desk. They just have to come there and try to find a peaceful place to work in. And many people interpret this as their employer actually not offering any good place to work, so they stay at home. This is definitely going to have an effect on how the working community is going to be formed. On the right side, you also see a workspace that is not really helping people. This is a space where everybody has their own room, and the doors are closed, and there is this red light on the door showing that please don't disturb me because I'm working. Now this is nice, of course, because you have peace and quiet in your own office, but it doesn't really help the work community to come together and discuss and support each other. So we need something different. We need something that helps people to come together and helps them also to help each other. We need great coffee rooms and things like that in workspaces. And this is something that we are still kind of in the middle of developing. Here are some elements of recovery. So recovery is a very multifaceted thing. It's not only one thing, but you actually need to have different types of recovery to have like a full possibility for recovery. You have to sleep well. You have to have your work life in balance with your other life, your family life and home life. You, of course, have to be able to enjoy weekends and holidays and so on. You also need to have breaks during your working day, and it is quite important to look at those breaks, what happens during the breaks. And in some workplaces, as we know, there is no possibility for having breaks during the working day, so that's definitely an issue that is increasing stress. And we also need those recovery moments. All of us need a way to recover. There's a huge market for this because people have lost their ability to recover. So you have yoga lessons and you have mindfulness training and everything like that. And you know the grandmother from Pihtipudas, this is a Finnish saying, she's laughing because she thinks that's really ridiculous. It's probably ridiculous to her because she has the great skills of recovering. She's the one who goes to pick the berries in the forest and takes her dog for a walk, and that's enough of recovery for her. But for many other people, we actually do need help in order to be able to recover in our busy lives. Also, lifestyle choices related to physical activity, sleeping, nutrition, these are things that are kind of private. People don't want to talk about those with their colleagues at work, but we are actually affecting each other at workplaces quite a lot also on these topics. And obviously the goal would be that there would be this kind of shared social habits that would help people have good choices and make good choices related to, for example, physical activity during the working day. So, for example, standing desks and all that stuff is shared between the people who are working in the same workplace. We know that physical activity is very important for mental health. There are lots of studies on this topic. For example, depression, which is a very important issue in the Finnish work life. We know that depression symptoms decrease even with very light physical activity. So this means walking slowly outdoors, for example. And also physical activity as prevention of depression, especially in people who have, for example, diabetes or another long-term illness. So these are really important long-term goals. And also anxiety and panic attacks, which are now an increasing problem in a Finnish work life. These can also be helped with physical activity, but in that case it has to be strong, tiring physical activity, long-lasting enough. We know that physical activity also affects memory. Here's a very nice intervention study where there were 120 sedentary adults, and they were divided into two groups, the blue group and the red group. And the blue group got a physical activity intervention. This meant that they went 3 times per week for a walk, and the walk lasted 40 minutes at a time. That's not a lot of physical activity, it's kind of a baseline level. But it actually had an effect on their brain structure. So you can see the size of the hippocampus depicted in the picture, decreasing in the group that continued their sedentary lifestyle, but increasing in the group who started walking. And it's also connected to the memory test results. So this is not a small thing at all. We also know that people are experiencing problems with their diurnal rhythm. It could be related to shift work, but most often it's just related to lifestyle habits. We know that the diurnal rhythm is heavily dictated by light, also eating, physical activity, and sociality. Those are factors that are affecting the diurnal rhythm, and this kind of diurnal rhythm looks very good, but how does it actually look like in practice? Well, this could be a typical diurnal rhythm. Where's the sun? I don't see it. We are just sitting in front of screens and there's no physical activity and often alone, working alone. So there are many factors that this kind of diurnal rhythm is affecting, but most important one is sleep quality. It can increase fatigue during the day, and it can also increase cognitive symptoms. So people say that I know I'm not at my best. I know that I could do better. I feel strange. And these are definitely symptoms of a poor diurnal rhythm. So what to do to this person now? How to make him move a little bit more, and especially during the daytime if he's working during the days, and how to give the sunshine during the daytime. It could be simple things like a habit at the workplace to go out after eating or to take the outdoors route to the restaurant or something like that. It could be small things that people decide together. Finally, I want to show you some data from a work fatigue study. Laura Sokka did her PhD on this topic, and she studied the cognitive symptoms of workers who have work fatigue. You know that people with work fatigue, they complain about their memory, they complain about their attention. But if you send them to your neuropsychologist to make a memory test or an attention test, they just get normal results. So they notice something in their memory and in their attention, but it is something that cannot be shown by neuropsychological testing of memory and attention. Obviously, those tests are not meant for this purpose at all. Here she studied the task of jumping from one task to another, and she found diminished frontal responses in participants with work fatigue. So the frontal part of their head was not reacting the same way as in those persons who didn't have symptoms of work fatigue. Everybody claims that jumping from one task to another is difficult, but it's especially difficult for people with work fatigue symptoms, and this is the data showing that. She also studied distractive sounds. When a person is working on something completely different, on a visual task, but in the same room there are sounds, somebody is speaking, somebody is saying something, and how does the brain react to those completely irrelevant sounds? She found that people who suffer from work fatigue symptoms, their brain gives rise to an altered response to these sounds. So the complaint that these people have about having problems in concentrating in noise, these data are showing that there is actually a neural basis for those problems. She also studied how the emotions in different sounds, completely irrelevant sounds again, how they are related to the brain responses. And she found that when you have neutral sounds, the brain responses are similar, but when you have negatively pronounced sounds, angry or sad voices, you can see that their brains are starting to react faster, as if they are trying to pick up all those angry, negative, sad voices from the environment, while these people are concentrating on a visual task, so they are not even listening to the sounds. This is an automatic reaction in their brains. You can imagine how this then affects their view of the working environment and the world they live in. This attention deficit trait is a word that is used for this kind of feeling when people experience problems with their attention. It's not only restricted to people with work fatigue, but also others experience these similar problems. They feel that they are easily distracted, they have problems in keeping their attention focused to a task. And obviously this is related to the way that the work is arranged. Is there a lot of interruptions? Is there a lot of multitasking during the working day? This will definitely change the way that our attention is working. So finally, some trends that I mentioned here in occupational psychology and work organization and mental health. Physical activity during the working day, choices in nutrition, sleep-related things, working times, shift work, and then also combining work with family life, measuring sleep, measuring physical activity, and what to do with those data. And then finally, the values that people feel about their work and how they are coinciding with their own values. Thank you.
Thank you, Minna, for the very clear and informative presentation. I think we may have time for one or maybe two questions or comments, if you have. Nothing online? What about?
Mostly praising that a good lecture, but not really questions. Very interesting information, this was good, erinomaiset viitamiinit, etc.
Thank you very much. This lecture, I think it gave ourselves a lot, and also when we have patients, we have now something to tell them also. So thank you, Minna. We will go on. Our next speaker is Emeritus Professor Klaas-Håkan Nygård, my colleague from Tampere University. He is from the Unit of Health Sciences, Faculty of Social Sciences, and he has a wide scope of occupational epidemiology and aging workforce. And during his long career, he has had a lot of international collaboration in this field. And today he will talk about new challenges and trends in ergonomics and human factors. Please.
Thank you, Rita. Dear colleagues, yes, I will speak shortly about a little bit about to remind you about the definitions of ergonomics, some challenges, possible solution in mainly physical ergonomics then, and then some conclusions. So just to remind you that the ergonomics, it's an old applied science since starting in the 40s, 50s, and was first very much about physical ergonomics, but then continue into cognitive and organizational ergonomics. And what else has happened also, that ergonomics is equal to human factors. Human factors is what they used already decades in the States and in some other countries. But nowadays, for let's say during the last 10 years, we combine these ergonomics and human factors, which is somehow a little bit strange, but that's the fact that some national ergonomic societies, for example, the Swedish one is now called ergonomics and human factors, but that's another thing then. So the ergonomics and human factors provides the knowledge and skills for fitting the environment, equipment, and activities to people. And you can see more about the definitions, if you like, from the IEA, Ergonomics Association's website. But the physical ergonomics then is, for example, postures, about postures, movements, physical workload, manual material handling, and so on. And then cognitive ergonomics, information processing, mental workload, human-computer interface, and so on. And then the third, organizational ergonomics, coordination of work processes, such as assembly lines, combination of work activities, work rest schedules, and so on. So, but today I will mostly speak about the physical ergonomics. And you can find more about ergonomics and human factors from the website of International Ergonomics Association. They have to the left a very new book about principles and guidelines. And not to forget then, let's say a little bit older ergonomics guidelines, which was prepared also between IEN and ICO, which was and is still some kind of bestseller, I think. So just to look a little bit at work changes. I think we all know already this, that sitting work, light physical work is increasing, and then the physical load, physical strengthful work is decreasing. And that has been ongoing since the 50s, 60s. And I don't think I have to mention about sitting or lying down. That sitting, prolonged sitting has been taken and discussed, that it's even as big problem as overstrain or physical overstrain nowadays. So just an example of how work life has changed. Here's forest work in the 50s, and then now forest work with machines, which has changed the physically very heavy work into sitting work and very much cognitive mental load. And these workers now are sitting in like an office, which I think is many times better equipped than our offices. So they're really very modern. But you can see also that the one result, one effect of the workload has same kind of, you have musculoskeletal disorders. If you think about blue collar, white collars, whatever, how you divide it, almost the same. There's not big differences anymore. But then I think you have to remind that work life still include physical work. And just some example here. To the left, you see a picture from where we started to a longitudinal study in the municipal sector in Finland. Some pictures about that, cleaning work, welding, kitchen work, and so on. And then a picture from now, and there's very much similar things. Of course, we have new tools and machines which helps us a little bit, but still there are much physical load included. So this is important to remember, of course. And what is then physical strengthful work? That's also a definition. It's a very, very low muscular load, for example, in office work can have strain, musculoskeletal disorders, for example. Then to go into a little bit, let's say, challenges and so on, and this is my COVID-19 part, then working from home, and you can call it telework. Telework is maybe then not just from home, from wherever you are then. And here are some statistics that one and a half year ago, let's say in Europe, about 1/3 of the working people moved home through to lockdown at workplaces. In Finland, it was much higher, 50-60% of the workers worked at home. And that's for some people very good and very nice, and that's maybe not a problem, but that's also like this in an article from Scandinavian Journal of Work Environment and Health. You can working from home, mismatch between access and need in relation to work, home interference and fatigue. So there are very much to do there at home, which maybe could have been easier dealt with at the workplace then. So, for example, some innovative solution from some of my colleagues and so on. You see, we have, all of us, I think, at least when lockdown came, we have to do some kind of solution, which you could say could be ergonomic innovations or whatever. And that's fine, but in the long run, of course, this is maybe not sustainable. So we did also, we are still going on with a longitudinal study in our universities in Tampere about working from home and COVID, other COVID things also there. And here, okay, so here we just one result from the study. It was more about, let's say, everything which concerned working from home, but here I took the working from home and effect on workability or work capacity, how you like. We started with T1 was in April 20, and this is then third time measured before Christmas last year, and now we have the fifth wave going on. But you can see here that not too big differences between the times. I mean, not too big. But then when you look a little bit more closer, you see somebody with a very poor workability there all the time. And then when we look at it, analyze it more in depth, we could say that non-favorable workability was associated with poor physical workstation at home, dissatisfaction with the support from the organization, high work stress, and musculoskeletal pain. And so you can see, of course, that for some workers it was all right too, and it's quite nice to work from home. But then we have also many problems with that. And just you can see for some solution now also that this is a copy from Japanese colleagues about how to telework or how to work from home. I think here the main message is let's say you have to have breaks and not sit 8, 9, 10 hours behind the screen all the time. And then also the variation, for example, in sitting or standing, sitting and standing, and so on. And you can find from the literature more and more guidelines now about this. Not too, let's say, difficult things and so on, but now when you're working at home, you have to read and think self. No physiotherapist is coming and tell you about this, like in the working place. No, then some ergonomic solution also. I think the ergonomics is, the slogan was already 50, 60 years ago that fitting the task to the man. That's the problem. And that's still very, I mean, what the ergonomics and human factors is about. And this is an example then about how you could, when with the increasing age, the worker is changing. but the work demands don't change if you or your employer change them. So you could say then that you could have a solution then to, first of all, if you think about ergonomic principles, you should change the work. But if that's not possible, then try to change the worker, of course. And I will shortly now show just a new, let's say a new old model of how you call it, which is a little bit a new concept or conceptualization about this fitting the task to the man. It's not only mainly called ergonomics, but it's very useful in ergonomics. And this is my colleagues from Denmark, Sweden, and Australia has been written a model they called, let's say, just right physical activity. So this is according to what they call a Goldilocks principle. I mean, if you remember the fairy tale about Goldilocks and the bear, Goldilocks asking up who is sitting on my stool and who is eating in my spoon and that so on. So this was just to say that try to fit the task to the man. And the first background is here what we can call physical activity paradox, which is has been known for quite a long time, but not that much discussed. This is that leisure time physical activity has mostly a positive effect if you not overload yourself and so on. But then occupational physical activity mostly could have another effect, a more negative effect, if it's too much of it. And that's very important then. For example, then in guidelines from WHO and so on, I see they don't differ between this and occupational physical activity and leisure time physical activity. The effects are really different. Then we know also that from, for example, rehabilitation, physical loading is of course good, but no physical loading is not good. That's also, if you take away from the work all physical activity, that's not good. You went into other problems then. And we know also that variation is good. So there's a time pattern is an important aspect of physical loading. And then, of course, replacing one type of physical loading with another does not necessarily improve health. For example, if you have a dynamic muscle work with heavy load, but then you can go into that you have more static load, which is also bad. So you have to think about how to change it. So they said just that just right balance is needed. Oh, I don't go into more into the principle. You can find them in the literature now. But that's you can see this quite something quite much old here, but also something new. And I somehow like this model because it's conceptualized very nicely, and then a good, solid scientific background. And they also now went in to look at some feasibility studies, and that's of course the important thing. And it looks like it's feasible, a feasible model. Then to go into some, let's say, what you call technological development challenges also. We all know that a robot automatization is good when the work is done so that the worker could be overstrained and so on. But then, of course, the worker if a robot take over, then the worker can be overloaded mentally again, and that's another thing then. But what I think is important in physical ergonomics is what we call cobots. They are collaborative robots intended for direct human-robot interaction, designed to work along human employees. For example, loading, unloading, transport tasks, and so on. So they cooperate with workers then. And they're used very much also, as you see here, the top 10 collaborative robot industries are listed there. So that's something which help people to maintain their workability or even promote. Then another thing which is maybe even more related to physical workload and physical ergonomics is the exoskeletons. They are support frames and or wearable devices for the worker to help the worker to work with physically heavy tasks. So we can distinguish here between passive exoskeletons, which help to perform physically heavy tasks. And that's then, let's say, more to prevent disorders and diseases, overloading. And then active exoskeletons is for rehabilitation, or also, if you like, for return to work. And the exoskeletons can steer or force the human to work ergonomically. That's a quite interesting thing also. So they can somehow teach the worker to lift or work in a proper working postures. So this is studied very much now, and they are now the prices of this went down quite a lot. So if I understood right, you can get some devices already for 1,000 up to 5,000-6,000 euros, which is maybe not so much then for more use for many in the workplace. So just to conclude this talk, then ergonomics and human factors has been an important practical discipline already for decades, and has still much to provide. Despite work is going more towards cognitive and organizational ergonomics, there are still a lot of physical demands as well as sedentary tasks in the work, which could be solved with proper ergonomic planning or new technology. So once again, I think the early slogan, fitting the task to the man, is even as important as before. Thank you. Thank you for your attention.
Thank you, Klaus Håkan. An excellent presentation. Do we have any comments online?
There is a question. What do you think? Do we have cobots in occupational healthcare to help physicians also?
So you need a cobot.
I don't know, but do we have those?
I really don't know. I'm not that much involved in that, but do anybody else know the cobots? Exoskeletons, I know, are in for example, in the acute healthcare. They to help people, nurses and so on, to lift patients and so on. But cobots for physicians, interesting.
What about in the audience? Do you have any questions for Klaus Håkan? Yes. Jukka, please.
Thank you, and thank you for a very nice presentation. I wonder if you or anybody else here have ever tried those exoskeletons. Myself, I had several different types of exoskeletons already in Singapore, and I found them really, really clumsy. And I'm not sure if they are at this time easy to use, at least just by buying exoskeleton from the shop and start using it for your own purposes. But if you have any other better experiences, that would be nice to know.
I don't have any experience, just Moni research in my group is dealing with this, and he has quite a lot. But I think they are lighter and lighter and better, and now when they put them into clothes, through wearable, then I think it could be a little bit different then. But they are not that clumsy like for some years ago anymore. That's my thinking, at least. But I think I don't know, this is like any technology. They may come and come but not that fast as we think.
Thank you. Thank you, Klaas Håkan. We will go on with the program. I have the pleasure and honor to introduce to you the next speaker, Dr. Paul Schulte, Director of the Division of Science Integration from NIOSH in the Centers for Disease Control and Prevention, USA. During his long career, he has written many articles and given several presentations about the global perspective of occupational safety and health in your future work. And today, we will hear how he sees our future challenges.
All right, thank you. It's really a pleasure to be here with you today, even virtually. I'm sorry I can't be there in person. Restrictions of our organization with regard to travel in the pandemic era are still prevailing. So I appreciate your attention as I go through my presentation. And so what I'm going to talk to you about today is the impact of technology on work and various perspectives on that. But the future of work is not just impacted by technology, it's impacted by a broad range of things. And you see in this diagram some of those other things, other factors: demographics, globalization, climate change, urbanization, political and economic factors, and pandemics. But clearly in the literature, technology is portrayed as the biggest driver of the future of work. And indeed, it merits the examination that I'm going to give it today. Now, technology has been growing, and there's been an acceleration in the growth of technology to the point that the growth is now exponential. And you can see the coalescence of many different events and applications occurring on the steep part of the curve. And indeed, it's expected that the growth will be even larger in the future. And the growth of technology, particularly artificial intelligence, automation, robotics, and in fact, the whole panoply of what's known as Industry 4.0, its impact on work is increasingly being considered by investigators. But the way it's been considered has been divergent in a number of ways. For example, there are two views of technology. There's a dystopian view and a utopian view. The dystopian view is that technology will bring less work, will replace workers, will end human work, and displace 400 million workers globally. That's one estimate. On the utopian side, however, as we've seen throughout history, new technologies and technology will create abundant opportunities for workers, boost the economy, increase capital accumulation, and create new tasks where labor has an advantage over machines. So these two views prevail in the literature, and indeed they have different implications. Certainly, in terms of the impact of automation, you can see that there are a lot of high estimates, from 40 to 61% at the high end of the range of jobs at risk of automation. This is what is prevalent, quite prevalent in the scientific literature. However, there are smaller estimates, anywhere from 5 to 15%, that also are showing up in the literature. But I think there's a general belief by many different kinds of practitioners and investigators that the number of jobs, or the percent of jobs at risk of automation, is clearly going to be closer to at least 50%. Now, this won't happen everywhere or at the same time or in the same way in each sector, and it will depend on a lot of different aspects. But regardless, historically, we've seen that the number of jobs created by technology has far outstripped the number of jobs eliminated. And indeed, it's hard to predict what a new technology will bring. And indeed, there are many examples throughout history where people have not envisioned how a new technology will change the whole profile of labor and products. We only have to look at the people who were diehard buggy whip investors as the automobile came into view in the early part of the 20th century. It may be, however, too, that the issue of jobs or no jobs is really a false dichotomy, and maybe a better way to think about this is to have a task-based analysis. And by that, I mean that instead of asking the question, will a job be automated or not automated, it might be better to look at a job as a whole array of tasks, some of which may be automated. Consequently, it may be that this will be the focus, the tasks that will be automated may be the focus where workers will need upskilling or new kinds of training. A overview of the kinds of jobs that may be subject to automation is shown in this slide, where we have both non-routine and routine tasks, be they cognitive or manual. And indeed, it appears that the routine tasks are the ones that can be automated or are likely to be automated. And this would include cognitive-based tasks or manual tasks. And this has been termed in the literature the routinization hypothesis. And indeed, if you look at data, these are data from Australia, but they essentially pertain to most industrial countries, you will see that the downward lines are the routine jobs, routine manual and routine cognitive, where the upward lines, and this is the share of employment by percentage over a 30-year period, the upward lines represent the non-routine cognitive and manual jobs. And so indeed, those are the ones that are growing. The ones that are decreasing are the ones that are likely to be candidates for automation. Now, it's been identified strongly in the literature that there appears to be a mismatch between the demands and needs and requirements of a new technology and the skills available in the workforce. And this question is not a clear-cut question. There is debate in the literature over whether the skills gap is occurring, and it's still a controversy. Nonetheless, it's it appears that there will be a lot of workers displaced, and these will need to be thought of by societies in different ways. Certainly, retraining and upskilling might be one of the ways, but other kinds of social support might also be important. So with that as prelude, what then is the future of work going to be like with the heavy growth of technology and its impact on the future of work? Well, we know that the world of work is changing. When I started in this slide was news. Now it's what most people are aware of, that the world of work is changing in terms of the nature of work, the nature of the workforce, and the nature of the workplace. The work is changing, and we have to be aware that even though work is changing, even in the future, it's going to be a mosaic of old and new hazards. We still may be dealing with lead and traumatic injuries, slips, trips, and falls, and so forth. So many of the old hazards will be there, but they'll be alongside many new hazards, and I'll talk more about this later. Work is also changing as it increasingly goes from from being physical to more mental. There'll be more service work. Work intensification is increasing, and people may have, and we're already seeing, many jobs in a working lifetime. The workforce is changing too. The workforce of the planet is aging on average. And so there are, and in some countries, more industrialized countries, we see a larger percentage of older workers. There'll be more immigrants, more women in work, less organized labor, less unionization. And the backdrop for much of the workforce will be the fact that as an older workforce, the burden of chronic disease in people who go to work will be increasing, and that will present new issues in terms of the future of work. And then finally, in terms of the workplace, we're seeing new arrangements of work, non-standard types of work arrangements, more telecommuting, more people working as contractors or temporary workers, indeed more small businesses, a decrease in social protection, which may color the future of work, and indeed the impact of pandemics. Curiously, as we look at the literature on the future of work prior to the pandemic, there was hardly any mention of pandemics as a driver of the future of work. I dare say now that was short-sighted, and indeed we think that many of the trends leading to the future will be accelerated by the current pandemic. So what I'd like to show you today is the results of 3 efforts that we had developed. One was a systematic review of the scientific literature and gray literature from 1999 to 2019, looking for scenarios of the future of work and hazards that might be identified or inferred from those scenarios. We also held 2 different workshops, one on training occupational professionals for the future, and one on how and issues in conducting research and practice in the future. And between these 2, we had about 90 participants, people of interest in the topic, people who were specialists in the topic in each of the workshops. And from these, I think we've learned a lot about the kinds of scenarios people are thinking of in the future, the hazards that might arise in those scenarios, and the impact, particularly of technology, on occupational safety and health and work in the future. Now, I'm not going to go through each of these 3 streams in detail. Rather, I'm going to give you an overarching and cross-cutting view of what was learned. And essentially what we saw were depiction of new scenarios, many that were involved transition from relatively standardized work and working time patterns to more complex, diversified, and non-standard working environments. It was depiction of scenarios that required more digital skills and new uses of data, scenarios that resulted from digital transformation of industrial production, and scenarios involving all the technologies described in the so-called Industry 4.0. We had some literature that pointed to the fact that employment contracts, because of these non-standard operations and temporary activities, employment contracts will be different. And a key finding, not surprising since we're already experiencing it, that many of the jobs of 2030 and beyond do not yet exist and are not being, hence, students are not being educated necessarily for them. This may sound a bit preposterous, but just think 10 years ago, we didn't have jobs of app developers or cloud computing specialists. And so indeed, many of the jobs of the future do not exist, and we'll have to work hard to anticipate them and the occupational hazards that might arise. We've looked around the world and saw that there are many different approaches to thinking about the future. We've used the approach by Hines and colleagues out of the University of Houston that essentially thinks about the future in terms of various kinds of scenarios, generally within the limit of plausibility. And indeed, thinking future casting is not predicting the future. It's thinking about alternative scenarios that could occur. And these are important to identify because we're better than just being victims of fate. The future isn't predetermined, and future outcomes can be influenced by our choices in the present. And so engaging in strategic foresight and future casting can move us from being reactive to being proactive, specifically about the design of job arrangements made, possible by digitalization. The types of work that are performed using these new technologies, and then the subsequent challenges to health, safety, and well-being. And so as we studied the scientific literature to identify scenarios, we were able to do that. And in that literature, we identified the kinds of hazards that were most likely thought by prognosticators and investigators to occur. And generally, you can see that the kind that started were the kind that were most likely to occur, most prominently depicted in the literature, were the psychosocial hazards. Very little thoughts about biological, chemical, or physical hazards in terms of being new or growing in the future. And indeed, here are the kinds of hazards or effects that were identified in the literature. And clearly, the issue of stress in a lot of domains was pertinent, stressful interaction with robots, but also the stress and anxiety that resulted from people looking at their employment or careers in the face of new technologies, a whole kind of scenario related to precarious employment. We're seeing that now. All of these things actually we're seeing now, but they're also being predicted to be predominant in the future. Decreased situational awareness, which can lead to a variety of catastrophic events. Blurring of work-home boundaries, intensification of work due to fast pacing and extensive amounts of work. Invasion of privacy due to the ability of technology to be able to be used to monitor every activity of a person, from keystrokes to bathroom breaks, as well as general productivity. The decentralization of work that we've seen in the pandemic is expected to be, and even before, is expected to increase in the future, and where there would be people working alone, and there would be some diminution or loss of social skills and increased loneliness. If you're familiar with the literature on loneliness, it's believed to be epidemic in some countries, and loneliness is strongly linked to many adverse health conditions. And then there's a need to think about technologies that can enhance performance. And so this line talks about performance enhancing drugs, but there's also a strong literature on performance enhancing exoskeletons and physical kinds of devices that can improve performance. All of these in some way have an effect on dignity and the dignity of the worker as they attempt to find meaning and perform meaningful work. Meaningful work that provides a living wage, meaningful work that gives purpose to one's life. So that one can have a family and a lifestyle that is free from extensive want. And then a lot of prediction of unemployment and underemployment, displacement of workers. You saw that figure earlier of 400 million workers globally who might be displaced from technological advances. And in these scenarios, in these new scenarios, we see further identification of hazards. So one set of the scenarios was where smart machines or smart materials, warehouses, and other factory systems continuously exchange information with human workers. And besides the adverse effect on workers, in some cases it may be to the point that it reduces the need for human workers in various kinds of jobs. For those that are not caused to be displaced, there's a need for more technical knowledge. It was talked about in the technology literature that that technology will make work more creative. It will get rid of the drudgery and make work more creative for workers. But in fact, many commentators believe work will only be creative for a fraction of the workforce and not broadly. Certainly, decentralized work, gig work, non-standard work is going to have issues with labor relations. There will be eroding of the, there appears to be, and predictions of eroding of employers, of the notion that employers have obligations to workers. And there'll be an evolution of the social contract, which is a nice way of saying that it probably will be weakened rather than stronger, made strong. And that's at least the tone in the literature. Another scenario, sort of a subset of the one I just showed, is the increased use of robots. Hazards depicted there include, again, job loss, and what's been referred to in the literature as automation anxiety. Concern about what an automated system will do. I'll touch on that a little bit later, but certainly it involves the issue of trust of robots and whether there will be a lack of trust, whether you can trust that a robot making a life influencing decision for a worker can be trusted to be accurate in doing that. And trust is a concept that, when you unpack it, has many levels and issues, but I think we're just starting to see people look at the whole issue of human-robot interaction in terms of trust. And then we'll see a lot of hazards that we expect from just machines in general: mechanical, electrical, thermal, noise, and a variety of traumatogenic hazards are all depicted in the literature. And finally, again, as we talked about, issues of loneliness and loss of social skills, reduced human and human-to-human contact. Now we're seeing a suggestion for the future of something that we're just starting to see now, and that is, for the first time in the modern economic era, growth is becoming detached from employment. Unemployment needs from employment. So that's a critical feature. Usually in history, there was a more commensurate relationship between productivity and compensation that workers got. But we're not seeing that, and I'll show you some data on that in the next slide. But the people who are not getting fair compensation or who lose their work are going to need societal protections. And we know that long periods of unemployment are health hazards, significant health hazards, and can lead to depression, anxiety, poor self-esteem, divorce, substance abuse, chronic disease, suicide, and mortality. And indeed, we're seeing this in a number of industrialized countries. So this is a slide that shows the uncoupling of labor productivity and compensation. The upper line is the labor compensation in both of these slides, and the lower two lines represent average and median worker compensation. You can see it started in around 1995 in the era after World War II. They were fairly close together, but now you see a divergence, and workers are not getting the level of pay that is commensurate with the level of productivity, and they're not then getting the level of pay that leads to a living wage. And so we're seeing inequality, and that is, in the literature, is what is being identified as a critical underlying factor in future scenarios. The concept of unequal distribution of wealth, income, opportunity, gender, and race is increasingly being described in the literature, and was found in the work that we did. And it underlays many of the scenarios in the literature. Many of the scenarios, and I've given other presentations to describe them in depth, were more winners and losers types of scenarios, and they result, or they show the unequal distribution of income and wealth. And this inequality at the individual level has important consequences that can affect health, employability, job maintenance, and job opportunities. And so it's good to see that societies are now focusing on this kind of inequality as an underlying factor, but there are many things that need to be attended to really address this. Now, we can talk about what kind of recommendations are in the scientific literature. Overall, the recommendations had a couple common elements. One was the need for collaborative efforts among stakeholders and other decision makers to shape the future. The future won't be shaped by just one group. It needs a broad coalition. And that is how we can get to a smoother and safer transition. But we also need more research on psychosocial risks, more research on where we can apply prevention through design kinds of principles to build out hazards, to design out hazards, be they at the molecular level, at the tool level, or at the organization of work level. So prevention through design is a broad concept that has to be further studied and more highly implemented in the future. And then we have emergent risks at all levels of production that need to be studied and looked for. And I'll talk a little bit more about how we anticipate and look for that. And one of the ways, though, is that we train the current generation of occupational professionals who are students, the current student generation who want to be occupational health and safety professionals to deal with future scenarios. Now, just drilling down a little bit more into some of the technologies that drive the future of work, or that may drive the future of work. We can look at AI and automation in general, and the lessons in the literature are that and recommendations for the future, that the occupational safety and health implications for new scenarios need to be understood. In other words, we need to start increasingly studying scenarios of the future and thinking about hazards and then interventions. Specifically, we need to look at situations where system controls which aren't fully understandable to humans or fully responsive in practice can lead to negative consequences, because when they are, in other words, they look good on paper, but when they were implemented, they didn't bring about the results that were expected, and this could lead to negative consequences, including health and safety impact on workers. Some of the investigations of the impact of these kinds of technologies, we need to be concerned about them and their quality. They may be biased to safeguard the integrity of the technical system at the expense of human operators. And indeed, this kind of bias may be built in algorithms, and it may be built in terms of the mindset of humans conducting the analysis. And then a critical factor that can influence workers' trust in automation and the operation of it is what's been referred to in the literature as mode confusion. And this is the breakdown in the interaction of users with automated systems. And essentially, it's when the user says, what is the computer thinking? What is it doing? What will it do next? This kind of confused state as the user tries to get information from a machine to understand the machine's state. And it's likely to continue and increase. And commentators noted that it's likely to increase in the future as human and machine interactions increase. One of the ways to think about dealing with the future is to think about ways to assess hazards in terms of old and new hazards, and in terms of traditional jobs and future jobs. And indeed, this table shows you, and it was in our 2020 paper, so you can study it in depth, shows you the ways to think about these kinds of hazards. And then with regard to future jobs, as I said, it will be a mosaic of old and new hazards. And it will be important to determine the extent to which old hazards are manifest in future jobs, how to adapt old guidance to new jobs, how to modify it, and to determine how to apply the old knowledge to these new jobs. And then when we look at new jobs in terms of the future, we can, this is where really there's need for creative thinking and building upon the nascent activities that are going on. So we need to be alert for sentinel events, and that requires identification of scenarios, new scenarios, and then what the sentinel events and leading indicators of adverse effects or of that scenario are. We need to do more work with forecasting. There's a growth of foresight kinds of activity. My colleague Jessica Streit and other colleagues have just published a paper in the International Journal of IJERPH on foresight work in occupational safety and health. I commend it to your reading. And then finally, and I'll talk about this further, we need not just to think of jobs, we need to think of the working life of the worker, the working life continuum, and I'll touch on this in a minute. The working life continuum is that whole period of one's career at work, and the need to assess the hazards that workers face over their life course. And to do this and to capture all the changes that are needed, there's a need for an overarching concept. And that concept is the concept of well-being. It's been described in many different fields. It's often used as a conjunctive phrase, health and well-being. But there's thoughts now that this may be the kind of overarching concept that can be used to gauge how workers are faring, workers and their family are faring in new technology scenarios. But for it to be useful, we need to be able to operationalize it. And there's a lot of literature occurring on new ways to operationalize well-being and occupational safety and health. And this will be especially important because we need, we have a diversity of adverse effects, adverse events and hazards leading to these. And the way for the occupational safety and health field to capture them is with some new types of measures. And so measures and concepts like well-being will be important. And indeed, in this slide, I show the transition and the evolution from the current traditional field of occupational safety and health to one that we say increases more broadly, where traditional occupational safety and health is also integrated with thinking about how personal risk factors interact with workplace hazards and how social and economic risk factors set the stage for workplace factors. And so we call this a horizontal enhancement, and that is coupled with a vertical enhancement where we look, as I said, at the whole working life continuum, and we look at the overarching concept of well-being. If you're interested in this model and hearing about its implications for the field of occupational safety and health, there'll be a virtual conference on this coming out of Houston, and X4OSH is its name, if you Google that. And here's the actual information about the conference. You can learn about that, and that's going to be December 9th through the 11th. I think some of the speakers at this conference, I believe Jorma is going to be speaking there, and it builds on the kind of things I've been talking about today. And indeed, so when we think of the workers in the future, we don't want to think about them, and the literature points to not thinking about them in terms of one job, but of their whole career and the cumulative effects of stressors in each of these jobs, plus the effects of this time between jobs, the intense effects of underemployment or of unemployment or underemployment, the whole anxiety and stresses of precarious employment need to be thought of in totality. And then in terms of well-being, we need to be thinking not only of well-being of the worker, but well-being of the entire workforce. And the field needs to focus more, and the literature talks about the need to focus on the well-being of the workforce. And you can look at that in terms of preventing threats, and you can look at that in terms of factors that promote well-being. And this is an area that if we're going to use an overarching concept such as well-being, we need to build out even more. So how can we influence the future? We can influence it by anticipating it, by using foresight techniques, by establishing robust regulatory regimes for the technology. Technology almost gets a free pass in some ways, and it needs to be assessed in terms of appropriate regulation at the appropriate times. There's a need to develop an ethical framework and codes of conduct for all these technologies that lead to digitalization. There's a need to continue and enhance and increase the involvement of workers in the implementation of any digitalization strategies. There's a need to focus on identifying the mechanisms to accurately predict which jobs will change and disappear, and the timeframes for those changes, and in fact, the geographical location. And then more broadly, there's a need for a reconceptualization of occupational safety and health in the future to be more holistic, a more holistic public health-oriented approach to addressing worker health. To do this, there's going to be a need to utilize more systems thinking and more transdisciplinary approaches. And finally, a goal should be to develop a more human-centered agenda for the future of work and occupational safety and health. With that, I want to acknowledge my colleagues who I've worked with on these studies, and thank you for your attention. Take care.
We want to thank Dr. Schulte for his excellent presentation that gave us a lot to think about and discuss about. We have a moment now, but we will have a possibility to discuss more after a short break. We will have a panel discussion at 3:45. If you go to take for a cup of coffee, please come back at 3:45, and we will have a very interesting panel discussion about the future of work and how it will affect our training and education of occupational physicians. So please be back then.
Check. Hej. Hei.
Okay, let's take the seats. We go to panel now. I'm sitting here. I'm standing here. Free seating, yes. Sorry. Okay. We have the last session of this meeting, and those most endurant are still left. We have panelists here. I start from the remote end, Professor Claudio Colosio, Professor Klaas-Håkan Nygård, Professor Minna Huotilainen, Professor Jukka Takala, Dr. Eva Helaskoski, Professor Leena Alamursula, and Professor Alenka Siernak. Welcome to panel. We have planned the panel so that we have 4 questions related to our 4 sessions, themes of our 4 sessions. And we are jointly chairing this panel with Jukka. And I will try to conduct it here, and Jukka will then react and comment and support me if possible. And we have those 4 questions which are here on the screen as well. And we will address the question to specific persons connected to their presentations and their fields of competence. But everybody can also comment any question if they want. So we want to be, we are going to discuss multidisciplinarity in the end of this meeting, and we are going to be multidisciplinary also in this panel. So don't hesitate to comment also if it is not precisely the question which was addressed to you. Okay, and the first question was related to the occupational safety and health, and particularly occupational health and occupational health services policies. We had the first session on policies, both global policies and some examples of national policies. And I have asked Jukka to comment this policy session, how he thinks we have to observe the pressure of changing policies, what are going to happen, what are the trends of the global policies and national policies, and what should we do in order to strengthen occupational health policies. Jukka, word is yours.
Oh, yes, perfect. Thank you very much. Thank you, Jorma. Maybe I start with one of the comments that came up when we were talking here, particularly Claudio over there was talking about the occupational list of occupational diseases, and I think referred to the wide definition of ILO of occupational health. So perhaps we could come back a little bit more on that kind of idea, to have a wide selection of what are possible occupational health problems, and perhaps also changing a little bit of the definitions or the terminology that we have been using. So rather than talking about work-related diseases, in the ILO definition, they are all occupational diseases. So we could talk about, frankly, about occupational, and sometimes we are linking occupational diseases to compensation, but that's not the case. I think prevention is always the key, and compensation comes always at the end. So that's one comment what I had at this time. Second comment, which I already take to some of my colleagues here informally, that I really wanted to continue with the Finnish model type here, and sometimes the model what we have had, it's excellent, but the reputation needs to be kept up to date. So we have to market our occupational health systems, our occupational health care system, the legal systems, the functioning service providers and things like that. It is excellent, and I can say from my experience, having visited almost every country in the world, this is, or if not the one of the best countries in the world, what we can have in this particular field. So how to keep it not only up to date here, but make sure that people know better that. And I think we are sometimes losing the international reputation if we don't be a little bit more selfish here in Finland. So this is my outside comment from this, to have an impact that government, that means Ministry of Social Affairs and Health and the Institute and things like that could have a more prominent role in marketing these excellent work what we have done. At the same time, making sure that we are keeping that excellent work exactly at the same level or going even further. It's not complete either. So it's my first comment.
Thank you, Jukka. Any comments from audience? You can also address through Presemo, and Asta will read them. If okay, probably you think for a while. We ask. Okay, Claudio, did you want to comment this question, which is very important, before you leave?
I'm very sorry. I'm trying to not to say a lot of words because, unfortunately, you know, I have my flight in few minutes. So, but yes, I think 2 points. The first is that the keyword of universal occupational coverage must become the objective of all of us, because the data collected from the reporting of occupational diseases show that there is a direct link with coverage and reporting of occupational diseases, and if occupational diseases are reported and the burden is shown, then the need of prevention comes. So this is, in my opinion, the link from what has said Jukka and my work on the list of occupational diseases.
Thank you. Any other comments from panelists? Okay, you are more professional than politicians, so you don't want to comment too much the policy issues. But of course, it is also important to know the policies, both globally and nationally, because it is really the background for everything what we do also. Okay. Should we move to the second question, Jukka? Should we move to the second question?
I'm sorry. Thank you very much for everybody, and sorry if I go.
Okay, Claudio, thank you so much. As I said, Claudio is the modern Ramazzini. Have a safe trip back, and let's meet again very soon.
Thank you very much.
Yeah. Second question? Okay. We have learned about new trends in occupational health, occupational medicine, and somewhat also, particularly in Paul Schulte's presentation, occupational safety and health. There are new contents, new activities, new service provision strategies. There are several changes in working life, so that our client communities, client organizations, and client individuals are going to be different. And partly they will be different after when the post-COVID era has been reached. So, for instance, telework, which was so much discussed by Paul, for instance. We also learned about the Rocco Kim's presentation on universal occupational health coverage. and what does it mean for occupational health professionals. Now I have invited Eva to comment this point because she is responsible Chief Medical Officer of Finnish Institute of Occupational Health and Occupational Medicine. So Eva, floor is yours.
Thank you, Jorma. And this is indeed a very broad question, and there's a lot of answers to choose from. You could choose globalization or climate change or anything. It's quite a lot. But I decided to choose 4 trends that I would like to discuss with you and perhaps hear some comments from the panelists. And the first one I picked was this new hybrid work, or the working at home and working at the workplace, and a combination of that. And that combined with the technological changes and perhaps a digital overload that comes with that. And I think that this is something that really challenges us. And I think the pandemic has given it a strong speeding up, but it was there already before the pandemic, but it has speeded up a lot. And depending on work task, depending on occupation or branch, it affects us in different ways, and it raises a lot of questions concerning stress and management issues, ergonomic, and a lot of things that we have heard of today in the previous presentations today that have raised these questions up. And I think this is a real challenge for the occupational health care to adapt to this and to develop the service. And we know that a lot has been done also in the occupational healthcare system, and we see a lot of new types to provide for the occupational healthcare also there, and a lot of these distance, technological things that we have seen there.
Okay.
Yes. And then the second one I wanted to discuss was this changing in work careers, and this has also been raised today. And I think previously it used to be for a lot of people that you got your exam, and then you went to work for an employer, and then you could work for the same employer for your whole career. But that's not the thing for a lot of people today. You work for a part-time, you work for a short time, you study in between, you can be unemployed and then go back to work already. And that, I think, it's a real challenge to take care of the workability and the well-being of the work task, and how we can. I think we should be better to collaborate, at least in the healthcare system, and between the specialist healthcare, the primary healthcare, and the occupational healthcare. I think we have a lot to do to smoothen up the path for the working age people to take care, so no one has to fall between during this. I think this is a big change. Then for the third one I chose was data. We have a lot of data accumulating in our systems all the time, and we should be better. A lot is done already in that field. We talk about big data and such, but still we have a lot to do, and I think we need to be better to analyze the data, to combine data, and to do research in that field, and to really use the data that is accumulating to make the right decisions and the right based on research. I think data is one thing that we see, that we have endless opportunities in that field, and they are getting better all the time, and we should keep up with that. The machines are getting better, and we should there's a lot to do for us also in this field of occupational health. And then the last issue I wanted to raise is actually not a new trend, but I think that this is one that we can't allow us to forget, and this has also been addressed today. It's the occupational hygiene and exposure assessment. And we have heard a lot of good presentations concerning this today also. And I think it's a risk that when we have so much to do in the occupational healthcare, that this part perhaps we don't have perhaps enough time and to train our knowledge in this field. I think we need a lot of multi-professional services and a lot of collaboration between different expert fields in this. And I share the concern, Jorma, with you that this occupational hygienists decreasing, the number of them decreasing in the whole world. I think it's something we need to worry about and try to.
Thank you. As I am retired, I'm afforded to take a very sensitive question now, and partly to Eva, but also anybody else, probably Rita and some others may comment. I have had a little bit battle with WHO and also Finnish Ministry and Finnish Institute of Public Health on whether occupational health services should be delegated to the hands of primary healthcare doctors and nurses and family physicians, which are very common in Europe, not so much in Finland. And my experience is also from the former Finnish situation, from that time when I started occupational health about 60 years ago. They are not doing anything else, and they don't know anything else but just that kind of flu polyclinic for workers. Nothing else. That was even Finnish Institute's occupational medicine department's main activity when I came to the institute. So what do you think about this integrating very tightly to primary healthcare and probably also delegating occupational health services for primary healthcare doctors? I know this is a hot issue, but yes, Lena.
I don't know if it's a hot topic, whether there is a trend of whether they would want primary care doctors to take over occupational health issues. I don't think so. We have had some good proceedings last years. Finally, there have been emerging referral processes. We have been inviting referrals to occupational healthcare system from other parts of healthcare. And finally, it seems that we have broken the ice and people are being headed towards our consultations. But it's not systematic, it's only emerging, and the worrying thing is that now that we're having a very large and profoundly game-changing healthcare reform in Finland, the instructions leave so much space for local solutions. There is nobody checking from above that every area will have a process of how to refer to occupational health care, how to collaborate. So during the last years we have done quite a lot, and now it seems that the vision is a bit blurred, whether this is going to continue or whether they're going to kind of forget. But we would need even the black holes of occupational healthcare to be written in the process flowcharts in every area. But if they refuse to even put the black hole there, then we kind of need to start over again. And in a sense, whether this is about occupational health policies or whether this is about services, maybe this worry was more about regarding all those new trends in occupational health policies. What is the will of the government? What is the will of the working life? How do they? What are the expectations? What are the tasks that we are given? It's a bit blurring, and that is a bit worrying. But on the other hand, like Schulte said, it is an option to develop occupational health care to be more inclusive of primary health care issues, just like in fact the development has been in Finland. We do our share of primary health care. And Schulte says that is one way of going forward. Okay. As long as we know what we're doing, it has its sides. But coming back to the original question, is it okay to hand over occupational health care issues to be taken care of in the general health care? I'm pessimistic. There are these ethical issues. There are these the mindset of what are the issues to be taken care of. They are different than those that we have, and we should polish up our knowledge and our potential and our collaboration side, and how can we help their work? How can we help them finding work-related origins of diseases? How can we help them in diagnostics and good care? That's what they breathe. and how can we help them in with this bureaucracy, with all these social security issues, helping people get employed and help saving them from extra statements, which they find tiresome, but we find part of our expertise. Maybe like that.
Eva, do you want to comment briefly before I give to Rita?
I very much agree with Lena. I think the solution is not to build walls or banners, say this belongs to us and you shouldn't touch it. I think there needs to be enough knowledge, know-how about occupational health care in the primary care. But then we need to be better on communicating what we do, what we are best at, and why this is a specialty. I think we need to be better. I think we have perhaps a little bit too much turned like inside, and we are happy to discuss together these things, but I think we should open up and also discuss and tell the rest of the system what we are needed for, how they can collaborate with us. I think we need to open, but I think it's good if there is, I think this includes that there should be some know-how also in the primary health care about work and why you should ask your patient what he or she does for her work and this. But I think Lena said it very nice.
Before Rita, you use the floor, I will present my statement which I have given in these discussions. Yes. Did you want Jukka to get the comment? Wait a minute, I will present my statement and then Rita and then you. I used to say in this discussion, also with WHO, I used to say that a well-trained occupational health physician can do both occupational health services and curative primary health care activities for his workers and clients, but primary health care physician is not able to do occupational health. My strange statement. Rita, please comment.
Is it working? Yes. Thank you. I also agree with Lena and with Eva. I could share some real-life experiences because we have had this EU-funded project where we have trained primary care physicians in 2 health centers to notice the problems in workability and to send these patients to occupational health care if they have such services, and if they don't, we have organized and hired coordinator in the project that takes care of those who don't have occupational health care. And we have seen that there is a need for this kind of service. There are in both small cities, there are about 7% of the patients who visit primary healthcare. They are in need of support for workability. And they don't have such services in health centers nowadays. Of course, we hope that this great reform that will start or really start next year or after a year, it may bring some solution for the unemployed persons, but I think there are still persons whose needs are not realized. So this system is not perfect, and occupational healthcare certainly has a very crucial role here. But I also agree that primary healthcare needs information, what occupational health services does and what it doesn't, what we can do, what we can't do, and how we can better communicate with each other. Thank you.
Thank you. I agree we have to collaborate. That's self-evident. Jukka, please.
Yeah. I think this idea of moving occupational health service to the public health, it's a bit like a simplified solution to the complex problem. And it's also comparable that if we would say that, okay, we don't need specialists, we just have a generalist to do everything. And I think that doesn't work like this. Then the generalist will have to be specialist in certain areas, have to be trained to be specialist. We don't say that suddenly oncologists will have to do oncologist work can be done by generalists. No, we need the specialist people in this, and also the occupational health specialist. We would undermine our own expertise, saying that our work could be done by public health specialists. It means generalists who are doing practically all diseases. These are needed, and also they have the big problems. Occupational health is still one problem in the whole society. There are maybe 90% of other problems but are not occupational, and they have enough work on those 90% to take care of those, rather than loading them one more and then removing the emphasis on the occupational health. I think we really need that one. And I think this is important, I think, to keep in mind. Also, I was recently in my own background, I was in the European Union system, and I'm still there, and for my life wanted to have a regular check, and I wanted to talk with the occupational health specialist in order to also consult and talk and see what he would think or she would think on that. And I got to see, then finally they guided me to occupational health physician. And it was really nice guy, but then he said more or less right away, he's not really specialized in occupational health. He's just a normal person, normal generalist. So he could never have that questions on what Bernardino Ramazzini would have been asked, what is your occupation? It wouldn't have been useful for him to ask questions, because I might have known more than himself. So this is something what is already a practice, that sometimes when people don't have enough specialists, then they give the work to the generalist, but that's not ideal.
Okay, thank you. Alenka, please.
Yeah, maybe I would.
Please use the mic. It's not on.
Is it okay? Now?
Now.
It
yes.
works. Okay, thank you. Maybe we should go back and underline the basic difference between specialists in occupational medicine and GPs. GPs are basically oriented to the health of individuals. First, they take care for their health. Of course, there is public health behind, but basically not. But the task of occupational medicine specialists is like Ramazzini said. We want to find a connection between hazard at work or exposure at work and the consequences on the health of the workers, not worker. So when we make preventive measures, we are not oriented at the individual worker, but on a group of workers that are exposed to the same hazard. So basically, our view and our activities are much broader and with longer consequences being visible in future times. Taking into account the current problem you are talking about are many times in many European countries a political problem when there is a lack of GPs. And it was a huge problem, I know that you all know it, the Netherlands, when the specialists of occupational medicine were put to take tasks of absence at work. And in fact, they lacked their activity as specialists in occupational medicine to be connected to workers at their workplace because they had to solve the problem of high sickness absence. And it was, in fact, drop down of occupational medicine in the Netherlands some way. So we have to underline, as we were discussing yesterday, I was asking how you say, what is the difference between occupational physician and specialists in occupational medicine? Because specialists in occupational medicine, we work on the second level, like specialists in internal medicine, surgery, and so on and so far. And our point of view and our tasks are different on the secondary level. But if there is no differentiation between the name of the doctors, they are easily misused or abused by the certain politicians or political situation when they are lacking certain profiles. As Jorma said, we can play a role as GPs, but not the reverse. So we have to keep on going and keep our being specialists in occupational medicine, not single GPs.
Okay, thank you for these comments. I would be tempted to ask them in writing and send them to Finnish government and Geneva headquarters. Okay, we go to next question. By the way, let's stop here. Any comments from audience? Do you have Presimo? Yes, good.
Yes, there are some comments, several comments concerning Minna's presentation, and some relating to the topic we have been discussing. Should we start from the...
It was for Minna's.
For Minna's, yeah.
Let's take it later.
Let's leave that.
We are now in this question, or
yes.
occupation, question B.
Yes.
Yes.
So there are comments that to the preliminary healthcare simply does not have resources needed to take care of OHO patients. And then comment to Jukka. Thank you for your idea about the Finnish occupational health. What are the platforms where Finnish occupational health could be marketed most effectively and how?
Len, please.
Marketed to who? If we want to market to the colleagues and multi-professional teams in the healthcare, it should be in the process flowcharts of how the healthcare system is reformed. It should be not marketed, but it should be automized. But then how to market this to working life stakeholders? Do our current clients use us as much as they could and as wisely as they could? Are we performing the best possible duties, and are we making the best of our knowledge, and are we doing work in where we can learn and develop our knowledge and keep up our occupational medicine know-how and things like that. That is one question. So marketing to whom? And then, like Schulte said, and what we have also recognized, the patterning of work contracts is changing. So following the idea of Ramazzini, go to the working life and see what are the strains and what are the good sides and what is the sickness profile in each occupation. What are the 3D printer people exposed to? What are the people who cycle our food in the slush there? The platform workers, probably totally lacking healthcare. What are those people who need to be phoenix birds and rising from the ashes every now and then because their professions vanish? Then they need to reorient. They need resilience. Do we support them? The current aspects of working life in light of Ramazzini, like anything, we go see and make some packages and further our understandings and then design services. We actually have. We have done a lot with the digital services as a discipline, much more agile development compared to pretty much any other part of the healthcare, but we could systematize. We could be more coherent. We would be more straightforward. Perhaps.
Thank you. Very nice comments. I like them. I would like to take 2 comments from my side for occupational health community. If we think we are the only competent who can do occupational health, we have to walk our talk. We have to be up to date. We have to understand the trends in working life. We have to be able to recognize the exposures. We have to be able to recognize the new occupational diseases, what we have learned here. So even we cannot rest. We have to take our responsibility. Otherwise, we can be replaced by family doctors or so on. Another thing which is conceptual. I used to write several conceptual guides in different books and publications, and therefore concepts are, I think, important because, believe or not, through concepts we understand the world. If we don't have concepts, we don't understand what is around us, even what are ourselves, what are we ourselves. Therefore, I would like to take a conceptual issue. I hope nobody will get offended, but when we did the first Finnish occupational health law, I was chairing that committee. The law was translated by ministry without sending the draft translation to us in committee and in the institute. And therefore the name of the act became Occupational Health Care Act, but it is wrong name. And I propose we will correct the name as soon as possible. I have been following that for decades, and I think I have been a bit lazy in that. Care is curative term. It means treatment of diseases and treatment of accident victims and so on. And this, the right name for Finnish Occupational Health Act is Act on Occupational Health Services. And this concept means that it is not only care, it has 5 elements. It has prevention, protection, promotion of workability, particularly care and rehabilitation. These 5 elements are in the Finnish occupational health law. And therefore, the care is wrong name. Could we, dear professors particularly, could we agree that we will change that term and translation? Because it has also some importance. Because as I said, concepts determine our intelligence and understanding. Would you like to comment, Professor Stitch? Jukka. Occupational Health Service Convention of ILO is ILO Convention on Occupational Health Services, not on occupational health care.
Absolutely, I think that should be the case. May I just use the opportunity to reply on the platform question that where can we lift the focus or lift the status of occupational health services and occupational health in general. I think there are lots of international possibilities to participate in that. I recall that the head of the ministry department at that time, my boss in the past in the ministry, he came to the ILO governing body. He was talking on behalf of the government. He finally came for a short period of time also a chairman of the ILO governing body, where you have talked to everybody there in the United States and UK and everybody who are the permanent members as a chairman of the governing body. So this is an excellent possibility to have an influence on everybody there. The same in WHO, participate in action in WHO and in the executive board and things like that. If you don't find other ways of participation, ICOC can organize it too. And also you can take care of the conferences. ICOC congresses in February now. Talk over there, open your mouth. If you don't have a particular option to speak there, you can always discuss and participate in the discussion itself. Jorma will certainly talk over there and I will talk over there. But I think we need a younger generation too to be present internationally. And I can guarantee that if you are present internationally, that will open avenues and you will learn a lot in that way. So I think that's exactly the case. Of course, one more thing what you can do, there's also something what is called social media, and that is very international. You can join that one too. In highlighting our work and our possibilities, we may establish special groups and teams and things like that in order to highlight those. So this is important.
Thank you. The concept of service includes not only those 5 substantive topics, but it contains also the involvement of psychologists, ergonomists, occupational hygienists, maybe even social scientists or social experts, social care experts, and also safety should be involved. They used to have a little bit separate organization, but we should at least collaborate with them. And the service concept is really broader, multi-professional, multidisciplinary, and not just curative medical, which modern occupational health should be also. Okay. Do you oppose? Yes, please.
I think someone has picked up really good comment in here. Please. I think everybody is thinking this, but everyone is so political, so please. Won't say this. But here is the comment. Many colleagues think that occupational healthcare doctors as GPs, but as gold diggers. Okay. So this is the word what actually is using here in Finland about the occupational healthcare physicians.
Okay.
Yeah.
Thank you.
And the comment continues, they just treat the flu. But this is not the case. And I think those who are saying like this really don't know what we are doing.
Okay, thank you for comment. Should we move to question 3? We have got a special session on training and education in the current world situation in occupational health and occupational medicine as well, and also in relation to, I would like to say, almost dramatic changes in the working life right now. And I have asked our 2 great educators, Alenka and Lena, to comment.
She has the magic touch. Education needs to be strategically oriented to answer to some needs in the society, and that's how we have organized our education. But there is so much to do. The occupational medicine side would probably need enlarging, but you need to start from somewhere and do things like that. I'm glad that you remember what I once learned from a pedagogical course. I learned in that course that if you don't know, you don't see, but it continues. If you don't know how, you don't do. So we need the theoretical knowledge, but we also need the skills, the processes, the management, the leadership, somebody looking after and encouraging us and inspiring us, and a little bit also monitoring that we do what we are supposed to do. And we have this imperative in this profession. We are here to act. So we have very much emphasized also the skills of understanding the logics of working life, the logics of social security, and really collaborate, do project work, get things done, find goals, and find project plans to meet the goals, and maybe that is the present emphasis somehow, which is also visible in our three goals, main goals. It's the relationship between work and health. It's the evaluation and supporting of working ability, much about plans, and then the side of really how to cooperate with the workplaces and stakeholders, including the idea that we are wise not to stop in workability. We are wise to go forward to employability, just like Schulte said. And it's a different world. You don't compare your things to the present working place. The reference is what this person could do afterwards, or if this workstation goes down. What are these people going to do next? What have they learned so far? How are they going to organize their next workplace? And really it's about supporting collective learning, really. To start with, Alenka, please.
Alenka, please. Well, thank you very much. I agree with Lena, and I would underline also one point of view I found after listening Schulte's presentation. He was talking at the end about predicting the future. And this is also what we need to know to talk about, because what we learned in this COVID situation, I remember that I was taught by my teachers, specialists of infectious diseases and epidemiologists, that there are bacteria and viruses coming we are not going to be prepared for because of such a huge use of antibiotics. So we knew what was going to come one day. And when it came, we are behaving as being not prepared for that. So from my point of view, The future is still unpredictable. Despite we are stating some items, we are not ready for the future. But I don't see the problem in not being able to predict the situation. But where I see the lack is the lack of communication skills, what came clear now in COVID times. And it was very special, at least in my country, also in Europe, in political communication. They were saying, if you are doing this and that in prevention of COVID, it will work 100%. If you are going to be vaccinated, you are going to be safe of COVID till the rest of your life. I'm joking a little bit, but the communication was something about like that. But for us who were used to work in researches, we know that nothing what we find out is 100%. We usually state odds ratio and confidence intervals. And this is what I think we should learn and bring to our basic communication with not scientific population, with working population, with politicians, with trade unions. And it is not so easy to get that skill, to be patient when you don't like the critics that comes to your shoulders. So this is one of the basic needs to reach about competencies and curriculum in occupational medicine, and maybe it is very good for the future of occupational medicine for COVID to come, so that we are urged to learn more than we thought we have to.
Thank you. Any comments from audience? Any Presemo comments?
I'd like to ask how Professor Minna Huotilainen does it, because you are very strong. You have a very strong presence in social media, and you popularize science efficiently. So where did you learn? Where can we learn?
Minna, please.
I don't know where you can learn it. I think it's learning by doing, at least in my case, yes. But I must say that writing the first book that was popularizing science, it changed my mind. So before that I thought that I can't do it, and that nobody's going to read it, and it's not going to be of interest to anybody, and that it's going to be time not well spent. And I've changed my mind about all of that now. So I understand that it's really, really important also for me to be able to explain in layperson's terms what I think, and how I feel. So I think it is worth it.
Thank you. Any further comments on this item? Okay, should we move to the fourth one? And now we are going to also the future element of working life and occupational health, and probably also occupational health and safety. But before that, I would like to ask our occupational medicine people and occupational health people, what kind of changes we should think and plan in view of the post-COVID situation where quite a part of work is done at home. What the services need for modification, the present occupational health services in Europe? Klaus Håkanen has thought about that.
No, the one important thing is how could an occupational health service person, employee, go home and for example, check the ergonomics or whatever. Is it legal? That is, I think, a big question. Of course, we can teach people to do something right at home, but difficult to check. So that's one important question. It's of course, you have to remember it's just in Finland, half of the working population who can work at home or telework, the other part can't. But this is, I think, an interesting question at least.
Thank you, Klaas-Håkan. I have discussed also during the breaks here about this issue with our ICO colleagues and some other colleagues, including Lena. I could summarize that conclusion from that discussion. It is that we have to go back to our basics, Ramazanian approach. We should not wait that employees ordering something or we are asked to do something. We have to take proactive approach, think us as occupational health professionals who are not only responding to the orders or needs of somebody, but also making our own, let's say, public health type action to look what is our constituency, how is it feeling, what kind of needs they have, what kind of risk they have, and make an intervention. I think this might be, according to present Finnish model, a little bit difficult, but we should try to lead the situation to that direction, because otherwise we are lost. Growing and growing number of workers don't have any employer. They don't have anybody who is ordering, and employers seem to be relatively reluctant sometimes to order any services, or if they order just the minimum. And if we simultaneously dream about comprehensive occupational health, which covers medicine, nursing, hygiene, psychology, ergonomics, and in certain part of working population at their homes. So I think we have to totally rethink our whole system for services. Klaas-Håkan, please.
Just in addition to that, I think we have to think more about public health in general, because if you think of somebody here, a lecturer, that workers are not continuing working from 20 years of age to 68 years of age. They can have many different kinds of jobs. They can have unemployment periods and so on. And then another thing is that we don't really know when young people are retiring. So, and that's something also, as we know that, for example, from our studies, that midlife workability, midlife health has a really much effect on old life. So, and then we are in the public health more. So I think, but that's maybe a problem, because what I have been seeing in our university, so medical students are not really interested in public health. They are then, after they have graduated and come back then and look at the world a little bit. So that's maybe something to come back to, as you said, basics.
Thank you. Any comments? Yes, Jukka, please, and then Alenka.
Yep. I think we have some foggy ideas of the future, but they are not everything is foggy, as Paul Schulte and everybody here mentioned already in some way or other. That, for example, we know that the workforce is becoming older, not only in Finland but practically in the whole world. The average life expectancy is going up, and we cannot just keep everybody being on pensions. Also, the working life expectancy is going up. So keeping people at work becomes a major issue for the societies, to keep the societies alive. And I think that is important thing for what can the occupational hygienists do. They did excellent work for the COVID-19 in identifying the aerosol business and highlighting those. What can they do for the other things, home business? What can we do for when people become older? They suffer almost anything more than others. Ergonomics problems, musculoskeletal, they are much worse for the older aging workers. COVID is also much more serious for for aging people and so on. So all this can be done, and nurses and those who can also go to different places and try to reach individuals. We have to find new methods to reach the people, not only the traditional thing that we wait them to come to our whatever occupational health service, but try to prevent exactly in the way what Alenka was mentioning, that we are trying to treat the workplace rather than treat the individual. I don't like, for example, the word of mental health of individuals, because it has already, the word mental health has certain stigma by itself. But if we talk about mental health of the workplace, that's a different thing. How can we make the workplaces mentally better for the people, of course? So if the workplace is healthy in terms of mental health, that would be important thing. So many different specialists are behind for that.
Thank you. When I was a young physician, I was a plant physician or biggest dockyard in Finland. And I considered I have 3 patients. I have the worker, I have the company, and I have also the, let's say, community. And you have to keep in mind that your workers is, of course, the key patient or key client, but not the only one. And we have to take the responsibility also the 2 others. I think the future development needs even more this kind of triple approach instead of single approach, which is in some places still very common. Maybe go to the 4th one, future perspectives, and particularly the requirements from the future developments which we have learned about Paul Schulte's and others' presentations. What does it mean for particularly multidisciplinary collaboration within occupational health and competencies to take part in multidisciplinary work? ILO Convention is defining occupational health service content really as so-called comprehensive multidisciplinary, which contains all those 5 elements which I listed, and also includes those professions, not only medical, not only nursing, but also psychologists, hygienists, ergonomists mainly, who are the most important ones. So how should we strengthen this multidisciplinary and simultaneously comprehensive approach? Minna, please.
Yes, I could take psychology as an example. So maybe the lowest level of collaboration between an occupational medical doctor and a psychologist would be that if the medical doctor thinks that there might be some problem with the worker's memory or attention or something, then send that person to a psychologist and ask for a memory test. But that's not really a very good level of collaboration, because if you have a person who is in the working life and you've met this patient several times and you've discussed with this patient and you've never noticed any problem with the memory, it's highly unlikely that you will get anything else from the psychology statement than that the memory is normal. So you send the patient there and then he comes back with a statement that the memory is normal. But still you know, and especially the patient knows, that things are not right. There is something. And I think this is a good example of a lack of words and concepts with the medical doctor and the psychologist. They are not sharing the same vocabulary. For example, the word memory might mean 2 different things to them. And how to actually ask the right questions from the psychologist, and what would those questions be? So I think that it would actually need training for both of them, both for the occupational medical doctor and for the psychologist. And my dream would be that this would happen in training sessions, so that you would have psychologists in training and occupational training, working together and trying to find that vocabulary and those questions that they could answer together. And I think that this becomes more and more important because the world is becoming more and more complex. And even the minor problems in the workers might lead then to bigger problems later because of the demands of the work, and especially how demanding the work is mentally and how demanding it's cognitively. So I think that this kind of training would be really important, but I don't know any way how to actually do it. So there's still probably some development needed.
Thank you. Klaas-Håkan, what about from ergonomic point of view?
No, yeah, I have more experience from teaching master students and also medical students, and there we have good experience from some courses putting together health master students in health, and also different from sociology. They were then working together in more like seminars and so on, and that was quite good. So they early get in touch with new professions, let's say, and I think that's happening in more and more. But I think that's a way to already from the beginning somehow understand each other. But if I think I have more teaching master student health students and more internationally, and the problem then in the medical faculty is that there's big groups and very tight schedules, so you don't have enough room for other professions or coming professions. That's something I think, if I remember right, it's just a small proportion you can choose then. For example, I have been in charge of a long time in public and global health for master students. And we have quite a lot of international students. We have international topics and so on. And it's not attractive so much from the medical students. I think that's much because of they have enough other things to do. But somehow to start already in that phase. Then later on, it's maybe another thing then, like here, then to how to do it.
Thank you. When we drafted ILO Convention 161 about 100 years ago, Jukka was already that time in ILO. I was chairing that ILO committee with 350 members, representing employers and employees and governments. We voted 262 times. I remember it because it was precisely the same number as the paragraphs in our report to the conference. We had an ideal model for occupational health services, which we were mistaken to design precisely according to so-called big industry model, having an occupational health service team with physician, nurse, psychologist, hygienist, ergonomist, safety engineer, who all would be in the same unit and working together closely from day to day. That was our ideal model. But we all understand now that it is no more at all valid. Even those big companies who used to have that kind of model, even in Finland, so-called Kymi-yhtiö model, even they have outsourced their occupational health services, including even Nokia did it, so that we don't have that model anymore in very many places. And therefore, if we want to reach this kind of ideal functional model for occupational health services, we should find new solutions. And what Klaus Håkan was proposing, it is one of the models, so that these collaborate together, but are not necessarily in the same unit. And I think if you have a small enterprise or individual worker, it is not possible even. We had in Finland nice solution, serving 36% of Finnish workers with occupational health service. It was municipal health service model, led by occupational health specialist and having a nurse, well-trained nurse. And they, health centers also had, for instance, psychologists who were supporting occupational health services there. But even that model has disappeared. We have to innovate new. Eva, you want to say something?
Yes, I will. Is it on? Do you hear me? Yes. Okay. I think there's still hope for the multi-professional work in the occupational health care. For example, at the Finnish Institute of Occupational Health, we give this training, as most of you probably know, this is mandatory due to the law that you have to have the training if you are an occupational nurse or psychologist or a physiotherapist doing occupational health care. And these courses are always multi-professional. And the number one goal of the courses is that you learn to work together, the professions together. And then you have all the substance, the things that you should know. But that's the one goal. And I was here lately I was interviewing together with Professor Reijola. We were interviewing physicians who wanted to start to specialize in occupational health care. And several of them said that they had some experience of working in the occupational healthcare system, and they said that they think that the best part of it that they get to work multi-professional, that they don't do in several other fields of medicine. So I think there's still hope for us in this field.
Okay, thanks. Lena, please. Technology doesn't collaborate.
Minna, I will take every opportunity to enjoy this international collaboration. This multi-professionality thing is it needs to be integrated to the need of overall development of the services. And now we come to the working from home and working in these hybrid situations, and also the what is it? It is this mosaic-like structure in business. In the stockyards, it is no longer one employer. I work at the university, and we always talk with the students. How many employers are there present in this very hall that we're sitting in now? And there is different employer for those who make food for us, and different employer for those who make the cleaning things, and then this university, and then there are might be private consultants and whatever. So who is the employer? Who are we working with? And what is the genuine knowledge about occupational health and how to convey it? There is the regulation says that the main employer in any place is obliged to give information to the others to be able to plan occupational health services for mutual working places. But then if some people work from home and some people, it adds a layer to this difficult thing, and adding this multi-professionality of teams there. It really, this is multi-layered and complex, and I can't think of anything else but using computers to help us with this confusion and all these layers, and somehow helping putting things together, using screening questionnaires and then throwing the ball wisely, using ergonomists, which we do far too little, using psychologists, using the most frequently used occupational health professionals there, and really sharing the work and dividing it and having a platform where the knowledge accumulates, and not forgetting the people in question, the employee, the employer, or the self-employed one, something like that. To make a blink in the eye, whether we should go to home. Okay, there was this saying when in former life that homes are dangerous places. So many people die at home.
Yes, thanks.
But this is silly. But really, these platforms. I am looking forward to the time when we don't have to make an artificial workplace visit to a workplace which doesn't have a workplace.
Yeah.
There are so many workplaces that are out in the wild. Where to go, what to check. We need to rethink it and find out what is a genuine understanding of occupational health and how to help those people and you know.
Thank you, Lena. Any comments from audience? Yes, please.
There are no new comments.
Please, loudly.
There are no recent comments in the chat, but I just want to encourage you and tell you that even though you might think, where did everybody go? They are online. There has been over 50 participants online during the whole conversation. So say hi to them.
Thank you, Heidi.
Okay. Yes, actually, I have a question. Have we recognized all the professions and all the multidisciplinaries in occupational healthcare? And I go a little bit further. 2012 in Cancun, I remember a session where actually educational sciences were presented there. And now working life is continuously changing. And we need to support also those actually poverty and poor people who are with lower education. And do we have tools for that? Do we have enough discussion about that subject? Do we have enough research?
Yes, Minna?
It might be sociology, the field that is studying this, and the situation of the working life and how quickly that is changing, and that's something that is definitely affecting occupational health. You don't have to go back in time more than maybe 20 or 30 years, and you would still have this kind of dichotomical situation in the working life, that you would have the entrepreneurs and then you would have the workers who are employed. But now when you look at the workforce, you have everything in between. You have people working on the platforms. Many of the entrepreneurs actually are that out of their own will, against their own will. They may be underemployed, they may be lacking of work, and so on. And then also many people who are officially employed by an employer still work in a situation which resembles entrepreneurship quite a lot. So there is this huge change which is kind of cutting away this dichotomy, and we don't really know what it means. And then there is also this polarization effect, that those who did well are doing even better now. You can see that in many data sets. You can see that in sleep data. You can see that in physical activity data. Those people with the highest pay and highest training, they actually flourish because of COVID. They have more time and energy to do those things that make them even healthier and make them do better. And then it's exactly the opposite in the other end. So these are really big questions that are about the whole society and how much an occupational health physician or nurse should actually understand this development and where it's going and what can be done about it, and especially what is the position of a single person in all of that puzzle.
Lena, please. Technology on.
I'm delighted to tell to anyone who still doesn't know it that we are so proud in this network to have organized a textbook, the first sociological and societal textbook ever published by Duodecim, the most famous medical publisher in Finland, and it's part of the national summative examination to read about some 100 pages on development of working life, including future perspectives, including much of the topics that we heard during the 2 days from several presentations, including Schulte. So there is up-to-date statement for our specializing physicians that this is relevant. You need to be aware of this. We show it very in a concrete way.
Thank you. I would like to advertise you that our international organizations, professional organizations, ICO, IEA, and IOHA, it means occupational health doctors and nurses, ergonomists, and occupational hygienists. We as professional organizations, we have made memoranda of understanding on collaboration. So we have started very early already this kind of collaboration, and we are also behaving in, for instance, World Health Assembly together. Jukka was last time there together with those two other organizations. I was once before, and so on. So we do really this in terms of the new developments in the working life. And I think we are much more stronger that way than being just alone. And of course we would like very much to get the psychological civil society to come, but we didn't really find quite a representative global organization. We have a fantastic psychological association, for instance, in North America and in Europe, but not global. That's the problem. But I think even Jukka, during his last few months, could try to organize that, if possible, with psychologists who are going to be the experts of future anyway. So I think we have gone through all our 4 questions, but any comments from the audience or Presemo? Please.
There were some questions concerning Minna's presentation, if I may ask them now from the audience. It was about the U-curve you presented, and the comment goes, I found it very useful even in discussions with clients, person or corporation. I would like to hear views concerning sick leave. Oh, sorry. In my opinion, in severe cases in work fatigue, it is impossible to jump from total exhaustion to workflow by only making changes in the work and working habits. In my opinion, in many cases, sick leave is needed in addition to the changes at work, but the Kela allowance system or even the general atmosphere in healthcare does not support it. How do you see this?
Panel.
maybe someone else. And
I think the question was that exhaustion and burnout, you ridden sick leave and Kela won't pay it, you don't have any incentive, so that's a little bit problematic. So what you have thinking about that, or anyone else?
Yeah, I can just comment that these extreme physiological conditions like this extreme work fatigue or then on the opposite side, this flow state, they are very, very far from each other, and it's not possible to like just snap your fingers and change something at your workplace and then you just jump to the other state. So I really believe what this person who was asking this question is saying, that you would definitely need a break. You would need a possibility to stop for a while. And it would be, of course, great if it was in the form of a sick leave, for example. That's all I can say.
And some continuance to the questions about the well-being and healthier brains. Is there a way or how to motivate individuals to a healthier life?
Thank you. Heidi, please.
A few recent comments.
The
few recent comments. The amount of international collaboration in our field has come clearly out today and yesterday. Excellent. And then a very interesting panel talk in any case. Thank you all. And then Minna Huotilainen rocks.
Thank you. Concerning the Finnish law, I have to confess that I lost the battle in the committee who was amending the law in 2001. I wanted to get defined members of the occupational health service team according to that what I proposed for ILO also, and we got it there accepted, that all those multidisciplinary experts would be members of the legitimate members of occupational health service team. But I lost the voting, and therefore the law is now, in fact, not probably functionally so different, but principally it is a difference. Because functionally you can make use of those so-called experts and get even Kela compensation for that. But they are not legitimate members of occupational health service team. So occupational health service doesn't need to use them if they don't want. And that's a difference. But I lost the game, I cannot cry. I tried very hard. Okay, now I think we start to be in the end of our panel. It was a conference, and the professor, when he got out from the conference, he was asked, how did you feel, what did you achieve in the conference? He said that yes, when we came here we were very, very confused. And we further are confused, but at higher level. I think we have got some clarity to issues, not confusing at higher level. And I would like to thank the panelists for giving very smart replies and answering very well, competently and clearly to our questions. And I think this is going to be used for also further discussions. I have a feeling that we need to continue discussion after this conference also in our team, and probably with our sister and brother professor chairs in the country who are far more than we. And think, what does this all mean for the development of occupational health in this country? So I would like to thank very cordially panel. I would like to thank the participants and also the present commentators to participation. Thank you very much indeed. And immediately I propose panel can move. I propose we move to the we move to the conclusions and recommendations. And I will have in the end the message from Professor Kari Reijula, who just did send it to me. Now we are going to close not only the session, also the whole conference. And please, loudly.
Just Kari Reijula just sent
yes.
to the chat, so I read that.
Let's read it in the last, because it has some content which is referring to the last point of this conference.
Okay.
You may have the same message as I have.
It might be.
Could you tell how? Wait a minute. I will check that we have the same message. Could you say the few first words? Yeah. No, okay. Then let's take it in the very last. I yesterday summarized the yesterday work, so I don't repeat that, but we will make notes on that and we will make use of that, because we are thinking to make some kind of, let's say, summary and conclusions of this whole event and distribute it, if not wider, at least to the participants and to, most of all, to our virtual university network. I would like to summarize our work here now with 5 points. In the case it might be substance for 500 points. So many aspects have been discussed. And my first point is that international collaboration, particularly at the European level, but also globally, is getting more and more important. And we have to take care that it works well in our discipline and in our professional communities. This is the prerequisite for us to give an effective response for the rapid changes in the modern working life and even in future. This is the first point. Secondly, research on occupational health and safety is needed to keep occupational health abreast with the developments of working life and also needs of workers, communities, employers, and the whole society. We have to take care that occupational health research is well represented in national research agendas and also well funded. Third, efforts should be continued to identify new occupational diseases, and according to the model by Modernet and Tor model. And we should also improve the detection and compensation of traditional and existing occupational diseases in order to close the gap of underreporting and undercompensation. Fourth, training should be developed in collaboration to renew the occupational health curricula, develop competencies and skills of occupational health specialists and experts, and also respond to the training needs of new developments in work life again. We should cover the themes of prevention, protection, promotion, care and rehabilitation, at least. Special efforts are needed, is the fifth point. Special efforts are needed to respond effectively to post-COVID working life. It would need new competencies and skills, new organizational models, new service provision systems, and also new policy and culture attitudes. Do you think this can be presented as a summary of this 2 days discussion? It's not very specific, but I hope it covers what we have discussed. Thank you. Thank you, thank you. Now it's time to really close. I would not like to do that because I would like to work with you. It is the time for vote of thanks. First of all, I would like to thank the speakers, international guests, and Finnish experts who have shared their knowledge and competence to us. We have learned a lot. I would like to thank the chairs who have been chairing the sessions, and of course also the panelists who have been making so good work in commenting here. I also would like to thank Jukka for supporting these 2 days' work. We have been in safe hands with Jukka, so thank you, Jukka, very much. Unfortunately, Kari was not able to be present, which is not fair because he was working so hard for this meeting. And I know he felt a lot of pain not being able to attend, but of course he made a right decision and highly ethical decision as well. I would like to thank Kari's team. I call these ladies Jorma's angels, according to Charles. They were helping me so much. And partly I would like to also thank Lena, who have taken care of our technology with the Unigraphia. That has been very instrumental and very, very helpful. I think technology has worked very well, except probably one AIDS microphone, which didn't work totally well. But we will understand and we will accept that. So the whole team, I don't mention the names because otherwise I forget something, and therefore it's better that whole Kari's team. You are, I would like to say, you are a star team, not team of stars, which means you are able to collaborate, not only looking at your own reputation and own merit. You work for the common goal, and I think it is very, very, very nice to see. Thank you really very much. I would also like to thank the hotel staff. You have been very helpful and very offered very good services for us. First of all, I would like to thank the participants, both the participants in person and those participating virtually. I have to once again say that we also thank very cordially the virtual speakers who were in distance. We used to say they were in abstinence. And they really earn our very, very cordial thanks. We have to thank also the tutors of our residents who came here, and they are doing the field work with the students there, and they take care of their competence and quality, which is very, very the most valuable asset for us. And of course, I want to thank Orion Company, who made our stay here very, let's say, pleasant and enjoyable, and also kept our nutritional level at healthy and safe status. We are going to distribute the presentations on your permission through virtual university. And also, as I mentioned earlier, some countries have already asked to get these presentations to their use for educational purposes, and I understood you accept that to be done, and we will respond to their request. I would like to encourage also the virtual university students and colleagues to make use of these presentations. I think it's quite a package of modern knowledge and competence and vision for future. Therefore, please use that. This may be also used widely in Europe, I think, and I hope you accept as well that. So please make use of this and not only leave it to the net alone. So I think, Minna, I've remembered to say everything what I should say.
Perhaps
my angel.
Yes, I think you have already. Thanks everybody.
Usually I forget something, and that's very bad for myself even in the afternoon. Okay. Thank you so much. And Kari will send you the message, which I will read to you here, because I think you hear it better when I use this big microphone. Kari's message to you is by thanking you. Also, keep safe and healthy. Take care of yourself. We will continue together from here. Great thanks to all. Safe travel back to home. And I propose we send Kari a message that please recover quickly in your family and take good care of yourself as well, and we will continue to collaborate. Is it okay to send that kind of?
He sent also another message that was, and thank you, Jorma, you are our hero.
Okay, this is at the end, but Minna and Asta want to say something still.
Yes, last days really has been teamwork, and we would like to thank all the chairpersons. I think that's neutral than chairmans. But please, Riitta Rauni, Leena Alamursula, really, really special thanks to you. Thank you. And of course, the whole seminar, the yesterday start for the seminar days and the whole leading role here, everybody who you get here to speak and talk to us, give new ideas. You have done tremendous work, your whole work life, but also this seminar what we have here. Professor Jukka Takala and Professor Jorma Rantanen. Thank you, thank you, thank you.